for traveling, just going off and getting and stuff like that. Stand out. There's actually lots of stands. Ari got discussed earlier. It's so easy. I'll take an individual pass. As they say not to do this, but I do it. Or in this case, they can like cook it frozen. And Ari spices is really tasty. It's got the skin on the bottom. You know, so you don't eat the skin, you just flake it off. It's wonderful. It's in a black box.
Like I said, I don't know if I have
some is most likely more fresh than we get
exactly. So this, I think I kind of explained it right. Every room's a little bit different, but so the the staff is except for right here, that's so he'll right but most of this oh no, then you guys will be right here. Alright, well, we can get this party.
non-technological, even when Make sure my phones are off. Like a refrigerator in here. We're all rushing from the caucus. Everybody's going nuts.
If you want to say something.
Well, you tried to call me.
Yeah.
Good. I'm going to try to find some more, so if you know anybody else.
Meeting of the Health Subcommittee is called to order. Today we're having a hearing on our collective battle against diabetes, the progress we've made so far, and the challenges that remain. Over 30 years ago, Congress passed the National Diabetes Research and Education Act, the first significant legislation directed at coordinating and expanding the government's research and prevention efforts related to diabetes. While we've made tremendous progress in understanding and treating diabetes, it remains a significant public health epidemic. It's staggering to realize that over 23 million Americans have some form of diabetes today, and the number is growing. Even more troubling is that 57 million Americans are at serious risk for developing type 2 diabetes, including women with gestational diabetes. Until recently, kids were rarely diagnosed with anything but type 1 diabetes, and the increasing rate of childhood obesity is changing the face of diabetes, though, and certainly not for the better. Now, as we'll hear today from our esteemed panels, diabetes is a leading cause of heart disease, stroke, blindness, and kidney failure. As is often the case, diabetes disproportionately affects racial and ethnic minorities. American Indians have the highest prevalence of diabetes, nearly 4 times those of white Americans, with Hispanics and African Americans close behind. Moreover, there's a clear economic cost. It's been estimated that over $220 billion in medical expenses in 2007 can be attributed to diabetes. And these are serious problems which need aggressive and innovative action. Today we're going to hear from 2 of our government witnesses from the National Institutes of Diabetes and Digestive and Kidney Diseases, located at NIH, and the Centers for Disease Control. Both will speak to their agency's role in doing landmark research and surveillance work related to diabetes and how this information has been translated into more effective prevention and treatment strategies, including the development of key therapies and technologies. I should add that NIDDK has recently celebrated its 60th anniversary conducting and supporting biomedical research to improve healthcare across the nation. NIDDK leads the nation's federal commitment in research, education, and health information dissemination with respect to diabetes and supports investigators who continue to make strides in research toward understanding, preventing, and treating type 1 diabetes, type 2 diabetes, and gestational diabetes. It's for these reasons that the ranking member, Congressman Shimkus, and I recently introduced a resolution honoring the NIDDK for its outstanding work. Now, on our second panel, comprised of leaders from the American Diabetes Association, the Juvenile Diabetes Research Foundation, and the National Indian Health Board, will also be able to shed light on the partnerships they have with government and in the community to maximize research translating to improve health outcomes. Lessons learned from innovative research, such as that funded by the Special Diabetes Program, have informed our efforts to address the epidemic today and will continue to do so in the future. I have to mention my home state and say that innovative, exciting, and collaborative work on diabetes research is taking place across the country in public-private partnerships, and I'm proud that New Jersey's life sciences industry continues to play a strong role in contributing to our ability to address the epidemic today, and will do so in the future. Before I turn it over to Mr. Shimkus, she is here. I wanted to mention that there were many members who asked for this hearing, but the most persistent one was certainly the gentlewoman from Colorado, Ms. DeGette. But I know that many members have asked that we have this hearing today. And also, my Native American friends have been asking that we have this for some time because of the high incidence of diabetes in American Indian populations. So, with that, I will turn it over to Mr. Shimkus.
Thank you, Mr. Chairman. I also want to recognize my colleague. That's on. The light's on. Can I get some help? Should I move?
Oh, it's not working?
No. You can't hear it.
Move to stay on this side.
What's going
Diana
on?
DeGette would like me to sit next to her, I know.
It's
We
completely-
have this debate all the time.
I hope it's working over there. Are they all out
We're
now?
being frozen out again.
Mine works, just the Republican side doesn't work.
We had to bring our own mics. I can do it. This one doesn't work. You're freezing out your own mic.
Well, sit here then. Go ahead. We'll switch.
Chairman's chair, I think that makes most sense.
Go ahead. I hope it works. How's that?
Don't let Mr. Waxman know about this. Okay. Let me, it's a great way to start. I do want to recognize Diana DeGette, also Ed Whitfield and Freddie Upton and Zach Space. And Diana is a rabid supporter and well known for her hard and diligent work. So there's a story we tell only to ourselves about our first term when we sat together way up front. And they moved us, so they moved me. Let me just welcome folks here. And as a member of the very large diabetic caucus and diabetes caucus and the work and from the whole community to help educate us, to help educate really children and parents and that whole plethora. It's a success story. Obviously, we would like to have the final success, which would be, cure, and that's the research and that's the disease management and that's what we should be focusing on. We will continue to express concerns about spending and the debt because budgetarily it'll affect our ability to get money to research and development. If we continue to spend more and more money on interest on the debt, then the discretionary money in the accounts that we have to do NIH, to do CDC, to do all the things that we need to do gets limited. In fact, USA Today, in their article, the federal debt will represent 62% of the nation's economy by the end of this year, the highest percentage since just after World War II, and that's according to the CBO. So when we raise issues about the new health care law, when we raise issues about spending and dollars, we are putting ourselves in a bad position to really focus on the things we want to do and set priorities as interest payments will start consuming that. So as we make those cases, we do that with the best intention. And this hearing is a result of a letter that was sent by Diana and her colleagues. We have sent other letters on the law that we hope will be well received too, whether it's the CMS actuary or of concern now are high-risk pools, which were promised in the new health care law, which some states can't fully fund and operate, or the states that have turned it over to the federal government because they're not going to manage it themselves. We have no idea what we're going to do, and those are promises we made as a nation with the passage of the law and the signing by the president. So we have to figure out how we can keep our promises. So I have a lot more I would want to say, but I know time is short, and I'll yield back my time and thank the chairman for letting me use his big chair.
Everybody may have to use it. We'll see. Thanks. Who's next? Thank you, Mr. Shimkus. And next is the gentlewoman from Colorado, Ms. DeGette. You got to sit here too, I guess.
Get out of the way for a while.
No, having everybody come up.
I assume you're going to try to.
Yeah.
You have your notes.
Thank you so much, Mr. Chairman, and thanks to Mr. Shimkus for his, I think, allegedly kind words. I really want to thank Mr. Space and Mr. Whitfield and Mr. Upton for requesting this hearing with me, and I also want to thank Mr. Green and all the rest of the members of this committee because we all share a collective commitment to addressing the issues of diabetes. The 250-member Congressional Diabetes Caucus is the largest caucus in Congress, and we strive hard to keep it that way. The reason is because diabetes is the fastest growing epidemic in this country, and it affects everybody, young and old. 24 million people have diabetes in this country. 57 million people, which is a quarter of all American adults, have prediabetes. So one of our tasks, as well as giving quality care and management to the people who already have one of the various forms of diabetes, is to try to get these other people back from the brink. And this is something that's difficult because most of those people don't even know that they are pre-diabetic. Have we made progress? Yes, we've made some. We know that effective patient self-management of an individual's own diabetes is arguably the most crucial part of an overall care regimen, and there's now a substantial body of evidence that diabetes self-management training is effective, but only if the patient has access to it. We also know that medical nutrition therapy can have a significant impact on preventing prediabetes from becoming full-blown diabetes. One issue that I've been increasingly concerned about, and I've talked to a lot of folks about this, is access to technology. Because as the mother of a 16-year-old with type 1 diabetes, I see the wonderful care advances that she has access to. But these advances are very, very expensive. She now has a continuous glucose monitor, and the sensors that she puts in once or twice a week, each cost $80 before insurance. So I say to myself and the members of the Diabetes Caucus, how can we make those wonderful advances in care and technology available to every diabetic, not just those who are fortunate enough to have parents with good health care coverage? We also know that disparities in minority populations are too prevalent, but we haven't done enough research to figure out how to mitigate the disparities in prevention, access, and treatment for these populations. So we've made progress, but when the incidence of diabetes in the U.S. continues to rise unabated, it's clear that diabetes has become, as described in this week's Lancet, a public health humiliation for our nation. The Diabetes Caucus is unwaveringly committed to tackle these challenges that are still unmet and to remove this humiliation. We will continue to press forward on all of the priorities, including making our hard-fought efforts to include certified diabetes educators as Medicare providers, to classify podiatrists as physicians under Medicaid, and many, many other priorities. The caucus is going to host a briefing on July 12th to address the growing epidemic of pre-diabetes so we can start thinking about ways to pull those 57 million people back from the brink. From prediabetes to type 1 diabetes to type 2 to gestational diabetes and even malnutrition diabetes, this condition comes at us in different forms. But the urgency mandates that we continue to work tirelessly to tackle the issue. And Mr. Shimkus is right. It's a health issue and it's also a cost issue. Because if we don't start putting the research into this issue now, it's going to overwhelm our healthcare system as my two young girls become adults. So I want to thank the witnesses on both panels for coming today. This testimony really helps us set our course as we move forward the rest of this year and into the next year to set our policy as a caucus but also as a health subcommittee. And with that, I yield back.
Next is Ms. Blackburn. I don't think her mic works either, so we're going to bring her up
This
here.
is the
Chairman's recording.
yeah.
Oh, we have one working mic, so we can just jump around over here. You're right. We're looking for two fast. Mr. Chairman, I do thank you for calling the hearing, and I want to welcome Mr. Buford Rollin, who is chairman of the Porch Band of Creek Indians in the Nashville area representative for the National Indian Health Board, and say a special welcome to him for coming in today, and to all of our witnesses. We thank you for attending. We thank you for the preparation that you put into the hearings as you come to us. Diabetes presents serious financial burdens and cost patients in Tennessee more than $3 billion in 2007. I had the pleasure of meeting the Gould family from Middle Tennessee last year during the JDRF fly-in. 4 of 8 children in their family suffer from type 1 diabetes. It is impossible to imagine the financial and emotional toll that this disease takes on each and every day for that family. With the 6th highest rate of diabetes in the nation, this is a very important issue to our state of Tennessee. According to the JDRF, over 10% of Tennessee's population is diabetic. In an annual obesity report released Monday by the Robert Wood Johnson Foundation, Tennessee was ranked the second most obese state in the country. A direct link between diabetes and obesity exists. We all are aware of that, and it appears that Tennessee is on their way to a diabetes epidemic. Due to the prevalence of this disease, the research, treatment, and prevention efforts are a significant focus for our Tennessee medical researchers. In fiscal year 09, NIH, and we thank you, granted over $17 million for research in Tennessee. The American Diabetes Association has 8 active research grants in the state. Mostly are focused on type 2 diabetes. Vanderbilt University Medical Center's Eskin Diabetes Clinic is in the midst of 10 clinical trials to develop treatments and learn more about the disease. And finally, in my district, we have 2 wonderful JDRF chapters. They are working actively to support those with type 1 diabetes, and the organization has given more than, get this, $55 million to Tennessee researchers. They are doing a great work. So for all of our agencies that are in the room, we thank you for the work that you are putting in. And these volunteers with associations are doing an incredible job in our state. So I join my colleagues in saying this is an area where we want to heighten awareness. We want to be more proficient in our education efforts, and we hope that we provide the proper support for the researchers who are trying to find a cure, a treatment, and disease management programs for this disease. I thank you, and I yield back.
Thank you, Ms. Blackburn. I'm told we're okay now with the mic, so we'll see. Next is our chairman, Mr. Waxman.
Thank you, Chairman Pallone, for convening today's hearing. The term diabetes describes a host of related health conditions that are familiar to us, and the facts are staggering. More than 20 million Americans have diabetes, almost 60 million more at risk for diabetes, leading cause of blindness and kidney failure. People with diabetes are at least twice as likely to die of heart disease or have a stroke, and diabetes is the 7th leading cause of death. It affects all age groups, both sexes, and every race and ethnicity. However, older Americans and certain racial and ethnic groups are several times more likely to have diabetes than others. That's why I'm glad that we are taking the opportunity to learn about landmark research accomplishments, ongoing efforts to translate what we know works into practice, and research questions we have yet to answer. Research has shown genetic causes, effective prevention for type 2 diabetes, and ways to delay and prevent complication. NIDDK, CDC, and other agencies within the department are working to ensure that our government has a coordinated effort to advance diabetes research and improve the health of those affected by this condition. Still, there is work to be done. We must continue our efforts to prevent women with gestational diabetes from developing type 2 diabetes later in life. We're not yet able to prevent type 1 diabetes, nor have we perfected the link between the continuous monitoring of blood glucose and the administration of insulin, the so-called artificial pancreas. And just this week, 2 new studies on the drug Avandia underscored the need to better understand and better treat type 2 diabetes. Underpinning all of this is the importance of a broad public health approach to this disease. We need sustained investments in research. We need people who have information to be emphasizing the point that diabetes is 24 hours, 7 days a week. That's why we support what the healthcare providers, families, and what is going on in workplaces to maximize each person's health and well-being. I want to thank the witnesses for appearing before us today, and I look forward to hearing their testimony. And with that, Mr. Chairman, I yield back my time.
Thank you, Chairman Waxman. Next is the gentleman from Georgia, Mr. Gingrey.
Thank you, Mr. Chairman. The World Health Organization has found that more than 150 million people suffer from diabetes, and it is estimated that this number will actually double by the year 2025. For at least the last 20 years, diabetes rates in North America have been increasing substantially, with about 18.2 million Americans living with the disease in 2002. Of those, roughly 90% have type 2 diabetes, which costs the United States as much as $132 billion a year. These statistics are a stark reminder of the impact the disease has on our nation, but also a reminder that the onset of diabetes for some Americans can be prevented. A majority of the patients with type 2 diabetes are obese, the connection being that chronic obesity leads to increased insulin resistance that can then develop into diabetes. Obesity in many forms is a gateway from which diabetes, heart disease, and other chronic conditions can strike American patients. Therefore, as we look at the federal response to diabetes, I would suggest that we also consider the root cause of obesity, reassessing the food stamp program so that healthy foods are encouraged, ensuring access to local parks and recreational programs, and promoting employer wellness programs, all the things that the federal government can and should do to encourage healthy lifestyles. We should also ensure that Americans with chronic diseases have access to quality health care. Unfortunately, President Obama's health care reform bill will make it hard for many Americans with chronic diseases to find care when in need. As many of you know, the pre-existing condition insurance plan passed as part of President Obama's health care bill, Patient Protection Affordable Care Act of 2010, will begin accepting applications in many states today. However, according to an AP article that ran just yesterday, and I quote, premiums will be a stretch for many, and the $5 billion that Congress allocated the program through 2013 could run out well before that, end quote. The Congressional Budget Office, in a report released last week, supported this finding when stating that the program's funding will not be sufficient to cover the cost of all applicants. Mr. Chairman, Ranking Member Shimkus has repeatedly called for hearings on the new health care law because it is deeply flawed and certainly can and I think will hurt our country. Since the day the bill was enacted, we have been reminded how this bill fails everyday Americans. Companies filing billion-dollar losses with the SEC, the Department of Labor reporting that half of all workers will actually lose the health plans that they have today, and many Americans with chronic illnesses will be offered health insurance that they just simply cannot afford. Mr. Chairman, I would urge this committee to act and hold hearings on the problems in the bill, President Obama's health care law. That being said, however, Mr. Chairman, I really do want to single out and commend Congresswoman DeGette for her efforts in addressing the incidence of diabetes in this country. She represents and is, I think, chairperson of the largest caucus in Congress today with over 250 members. Her leadership in this area is laudable and worthy of recognition by this committee and by myself, a practicing physician before I got this job. And with that, Mr. Chairman, I'll yield back.
Thank you, Mr. Gingrey. Next is our Chairman Emeritus, Mr. Dingell.
Mr. Chairman, I thank you for your courtesy and I commend you for this hearing. First, I wish to recognize the many members of this committee who have continued to beat the drum on this disease, and I thank them for their leadership. It is safe to say that we have a diabetes epidemic on our hands. More than 24 million Americans are afflicted with the disease. That's more than twice the number of people with diabetes in 1997. In my home state of Michigan, more than 680,000 people, 8.6% of our population, struggle with the disease daily. In addition to the major health complications caused by diabetes, the economic toll of the disease is considerable. Diabetes costs the U.S. economy $174 billion every year. 1/3 of every Medicare dollar is spent on people with diabetes, and already stretched state Medicaid programs are confronted with the growing costs of diabetes care. Since the passage of the National Diabetes Research and Education Act in 1974, the federal government has worked to coordinate diabetes activities amongst the various responsible agencies, most notably the work of the Center for Disease Control and Prevention and the National Institutes of Health have taught us a tremendous amount on the causes of this disease and ways to control and prevent it. Because of our surveillance, education, and treatment activities, individuals today with diabetes live longer and healthier lives than people who were diagnosed with the condition in prior decades. However, rate of new cases of diabetes continues to increase. As a result, the gains in control and treatment are being overtaken and submerged by the increase in the number of people acquiring the condition. The recently enacted health reform law will address the many abuses employed by insurance companies to discriminate against those with diabetes, and I am extremely proud of that fact. Additionally, the new law provides access to the necessary tools to manage and prevent diabetes and its complications, including the creation of a national diabetes prevention program, a national report card on diabetes to be updated every 2 years, and state grants to provide healthy lifestyle incentives for Medicare beneficiaries. Now, these steps will go a long way in our fight against diabetes, but more can and should be done. We must ensure our approach is consistent with current science and with understanding the disease. Our approach needs to be comprehensive, and it must ensure that all we do and that we do all we can to prevent the onset of the disease, to ensure the diagnosis of the disease is conducted in the most efficient and accurate manner, and to ensure that our people have the best methods available to control the disease, and ensure that diabetics have the best treatments and medications available to prevent complications. The instrument that we make in defeating diabetes will have an enormous impact on the health of our nation. Thank you again, Mr. Chairman. I yield back the balance of my time.
Thank you, Chairman Dingell. Let me announce that they just called 3 suspension votes, but I'd like to take one more speaker and then we'll recess and come back, which should be about half an hour or so. And next on my list is the gentleman from Kentucky, Mr. Whitfield, and after you, we'll go vote.
Well, thank you very much, and I certainly want to thank the witnesses for being here today. We appreciate very much the commitment that you have made to help us find a cure for this disease and to reduce the number of people that unfortunately have it. And I also hope that those in the audience are not disillusioned that Republicans and Democrats are so joined together on this issue. And but I do want to thank Diane DeGette and Henry Waxman and Frank Pallone, as well as John Chimkus, Joe Barton, Fred Upton, Zach Space, and all of those who are involved in and interested in this issue. 2 months ago, I was down in my district and I met with the parents and 6 teenagers who all had diabetes. And we frequently, those of us who are laymen, think that what you eat and your weight is the determining factor of whether or not you have diabetes. But when you talk to these young teenagers, all of whom are very thin, very energetic, all of them have diabetes, and then you realize what they go through every single day with the testing that they do, with the monitoring that they do, watching the foods that they eat, the emergency runs to the hospital they make, and the impact that's going to have on their entire life. It does bring home very clearly the impact that this disease has. Other speakers have talked about the statistics and the cost and the impact on the number of people in our country. And so I think this hearing is very important. I certainly want to thank Diane DeGette for sort of leading the charge. I know that all of our physicians on this panel, Dr. Gingrey and our friend from Texas, Dr. Burgess, have a particular interest as well. So we look forward to your testimony to help guide us as we move forward. And I also want to point out that while the federal government is spending a lot of money on research, we also have some private companies that are spending a lot of money on research. And one that I would like to particularly mention is Novo Nordisk, which happens to be a company in Denmark, but they have 4,000 employees in the U.S., and the federal government is the U.S. federal government is the only entity that's spending more money on research on diabetes than is Novo Nordisk. So I want to thank them and their leadership team for their commitment to this disease as well. Thank you, Mr. Chairman.
Thank you, Mr. Whitfield. We have time for one more before we break, so I'm going to ask our Vice Chair, Ms. Capps, to do an opening statement.
Thank you, Chairman Pallone, for holding this hearing, and it gives me an opportunity to thank my seatmate here, my colleague Diana DeGette, as well, for bringing us all together around this issue, and on behalf of the entire diabetes community, because as I was just mentioning to her, this is a very well-organized group with juvenile diabetes and make visits to their members of Congress regularly, and I want to applaud them for doing that. It really has an impact on us. I look forward to an update today from our esteemed witnesses on the progress of diabetes research. After all, despite all the promising discoveries over the past several decades, there still is no cure, no surefire way to prevent the development of diabetes, especially type 1. As many of my colleagues know, I was a school nurse for many years, and if there's one disease that's sure to bring a student, a frequent visitor, into the nurse's office at school, it's diabetes. So I certainly became very familiar with the maintenance of type 1 diabetes, and I had been hopeful that by now we would have something in place, but there are many promising things on the horizon, which is exciting to know about what we're going to learn today. The sad truth, however, as my colleagues have indicated, is that children don't suffer today just from type 1 diabetes. There is such an increase now in the incidence of type 2 diabetes. I know there are definite steps to prevent the onset of type 2, and we can take in our communities, such as increased physical activity and better nutrition, but we need also to be creative in how we get the message out to at-risk populations, especially minority ones, and design programs targeted for those populations. I think particularly of programs in my district such as St. John's Latino Health Diabetes League, that initiative in Oxnard, California, which is tailored educational programming to at-risk communities. But they can only do this with the right type of evidence-based research being conducted at the institutions represented here today. So I'm especially curious today to learn more about how you're working to equip our local communities with the tools that they need to address diabetes prevention and management. I look forward to hearing from our witnesses about the exciting work you're doing now and on how Congress can better work with you and help you to achieve our shared goal of finding a cure. So I yield back. Thank you.
Thank you, Ms. Capps. So we'll now take a recess for the 3 votes. You're next. I don't think that'll work. The committee stands in recess. The subcommittee hearing will reconvene, and we'll begin with the gentleman from Texas, Mr. Burgess.
Well, I thank the chairman for yielding. The hearing this morning focuses on an important public health issue, obviously a significant impact on our nation and a crippling effect on our budgets, and we've already heard statistics from a number of members this morning, so I won't repeat those, only to mention that my home state of Texas, over 1.5 million people over the age of 18 have diabetes, and in our state it is the 6th leading cause of death. Two bills which I would like this committee to consider to move expeditiously and mark up. Of course, we've already heard about H.R. 3668. Representative DeGette would reauthorize the special diabetes programs for type 1 diabetes. This program was started back in the 90s under the guidance of then Speaker Newt Gingrich, and he continues, as do I, to support the innovative work of this program. In fact, there have been some rather dramatic things that have come out of this program, including autotransplantation of beta cells from people who have had a traumatic disruption of the pancreas. Now, I also have a bill, with Elliot Engel, the Gestational Diabetes Act of 2009. Having practiced as an OB-GYN for over 25 years, I'm clearly well aware of the problems of untreated gestational diabetes affecting over 200,000 pregnancies a year, over 7% of the pregnancies in this country. And they can have significant impact on both the mother and child because they are at significant risk of developing type 2 diabetes, and mothers are almost 3 times more likely to have a recurrence of gestational diabetes in future pregnancies. As with other diabetes trends, the rates of gestational diabetes are higher among women of African American, Hispanic, Asian, and Native American descent. H.R. 5354 creates a research advisory committee headed by the CDC to expand monitoring, including coordinating efforts to help mothers avoid contracting type 2 diabetes. So I would urge members of the committee to co-sponsor this legislation. It does just so happen that I have a sign-up sheet for anyone interested in co-sponsoring this bill, and Mr. Engel and I would be happy to take that to the floor to save you the trouble. While we hear about the increase of obesity in the United States, and it has raised the prevalence of diabetes generally, we also need to hear about the impact of genetics, ethnicity, and maternal age, particularly in the case of gestational diabetes, and focus our research on much of the how diabetes costs can be reduced through better lifestyle choices. With the correlation between obesity and lower income levels in diabetes, this committee really needs to stress being involved in encouraging proper nutritional choices for our populations that we serve under Medicaid, which is under our jurisdiction. So I thank you, Mr. Chairman. I will unbelievably yield back the balance of my time.
I'm supposed to take notice, I guess, right? All right. Thank you. Thank you. No. Next is the gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman, and Ranking Member Shimkus for holding this hearing today to discuss the yet unmet challenges facing us regarding diabetes. And thank you also to Diane DeGette for her leadership on this issue. I'd like to welcome our witnesses today and on both panels and recognize, in addition, the 60th anniversary of the National Institute of Diabetes and Digestive and Kidney Disease, and wish you many more years of leadership in conducting and supporting biomedical research. I too also want to thank Novo Nordisk for their work on diabetes, both in the lab and in communities like mine, which has a prevalence of diabetes that's far higher than the national average. Diabetes is a disease which strikes at every age level and in every racial and ethnic group in America, and while it does still disproportionately affect the elderly, the fact remains that its prevalence is growing among all groups. In addition to the nearly 24 million people currently living with diabetes, there are 57 million estimated to have prediabetes, putting them at increased risk for developing diabetes and complications therefrom. Particularly disturbing to me is the increase in type 2 diabetes in children and the racial and ethnic differences in prevalence of diagnosed diabetes. When nearly 12% of non-Hispanic blacks, more than 10% of Hispanics, and an unacceptable 16.5% of Native Americans and Alaskan Natives have been diagnosed with diabetes, compared to 6.6% in non-Hispanic whites and 7.5% in Asian Americans, it's undeniable that aggressive action must be taken to address these disparities. It's also alarming that the prevalence of a disease which 100 years ago was unknown to them affects now Native Americans and Alaskan Natives at a rate that is more than twice that of their white counterparts. It's because of these disturbing facts that I'm especially pleased to see that Mr. Buford Rowland is present from the National Indian Health Board. Although the diversity that exists among Native American and Alaskan Native populations must be recognized, your presence here is certainly a step in the right direction in giving these populations a voice on this issue and ensuring that the diversity that exists on every American health issue is not overlooked or forgotten. It has been over 35 years since the Interagency Committee to Coordinate Diabetes was set up at HHS, and while advances have been made, in that time diabetes has exploded, especially in the South, in racial and ethnic minorities, and type 2 in children. So I look forward to exploring today what's going to change going forward so that we can reverse this really terrible trend that we're seeing in our country.
Will the gentlelady yield to me before she yields back, just for a friendly purpose? Early, I thank the gentlewoman. Early, a member on our side of the aisle recognized a couple of physicians on the committee and on the subcommittee, and he failed to mention Dr. Christensen, who has came to this Congress from the Virgin Islands, having practiced family medicine there for many years, and she knows of what she speaks. So I just wanted to recognize that fact.
Thank you for that. I yield back now. Thanks.
I thank the gentlewoman. Next is the gentleman from Ohio, Mr. Space.
Mr. Chairman, I will enter my opening statement into the record on the condition that I'll be allotted additional time for my
That's how we work.
Questioning. And I would like to thank you, however, for calling this very important hearing, and my gratitude should also go out to Diana DeGette for her leadership, and to Ed Whitfield and Fred Upton for joining me in the request for this hearing.
Okay. Next is who's here? Gentlewoman from Ohio, Ms. Sutton.
Thank you, Mr. Chairman, and I too appreciate you holding this hearing today. This is an incredibly important hearing to have. I, like so many members of the subcommittee, care deeply about diabetes, and I am a member of Ms. DeGette's Congressional Diabetes Caucus, and I thank her very much for her tremendous leadership. Yesterday, a young woman from Northeast Ohio, Selena Williams, came into my office. Selena is a 15-year-old and was diagnosed 2 years ago with type 2 diabetes. As you can imagine, and some of you in this room have experienced personally, this was an incredibly scary time for Selena and her parents. She was very lucky to be able to participate in a treatment program at Rainbow Babies and Children's Hospital, which is home to a Center for Excellence for Childhood Diabetes, Activity, and Nutrition. And through Rainbow Babies, Selena and her family joined a program called the Today program, which stands for Treatment Options for Type 2 Diabetes in Adolescents and Youth. The Today program's goal is to study the best ways to treat type 2 diabetes in children. And in the Today program, Selena and her family learned the basic skills that she would need as a diabetic: how to test her blood on a home meter, give insulin shots, and manage high and low blood sugars. And she also learned through home visits with a certified diabetes nurse how to make lifestyle changes to help her and her entire family be healthier, such as how to read food labels, manage portions, and stay active. And through the Today program, Selena has improved her health. And she recently did something that she said she never thought she would do. She tried out for the freshman basketball team, and I'm proud to report that she made it. Sadly, there are millions of children like Selena, but not all children have the same treatment opportunities or educational programs that Selena has had. But all of those children have great potential. And the fact that they don't have that opportunity is heartbreaking. So I look forward to hearing about the progress that's been made in the battle against diabetes, and about the work that still needs to be done and what we can do to help. Thank you, and I yield back.
Thank you. Next is the gentlewoman from Illinois, Ms. Schakowsky.
Thank you, Mr. Chairman. You know, if for no other reason, we should, as policymakers and as taxpayers, pay very close attention to diabetes. According to a Mathematica report by Drs. Marcia Gold and Renette Briefel, diabetes costs the government, just the government cost, $80 billion a year in medical costs. That's Medicare and Medicaid, and I'm sure veterans health care, et cetera. The CDC's testimony reports that national costs for 2007 exceeded $218 billion. That includes private insurance. So if we were to really target diabetes in terms of research, in terms of the kinds of public education programs that Congresswoman Sutton talked about, and in controlling this disease, we would also be able to save billions of dollars and change lives forever. Diabetes is really a very cruel disease that affects 23.6 million Americans. It's cruel to young children who have to draw blood every day, monitor their sugar and their diet, which is a good thing for all children, but in the ways that diabetic children have to do, it's really difficult. And to millions of adults who develop diabetes later in life, particularly for type 2, where there really are lifestyle kinds of changes that can be made. We need to invest in public health programs. And for all the rest of diabetes type 1 and also type 2, we need to invest in research. So I want to thank Congresswoman DeGette, who has been a champion for her throughout her career here and even earlier on addressing this important disease, important in so many ways, and a disease that we can, in so many ways, effectively address. So let's do it. I yield back.
Thank you. And next is the gentlewoman from Wisconsin, Ms. Baldwin.
Thank you, Mr. Chairman, and Ranking Member Shimkus for calling this hearing today. And I, too, want to echo my colleagues' comments of gratitude for the leadership of my friend Diana DeGette on this issue. I also want to welcome all the witnesses that we have today. We're very much looking forward to hearing your testimony. Diabetes clearly has a sweeping impact on our society, and in that vein, I'd like to share the story today of a very brave family making a tremendous difference in my district and across the state of Wisconsin. The Wickmans are just like many other American families. They love the outdoors, they love to take road trips on weekends, and they would do anything for their children. Yet this family has really been ravaged by diabetes. Grandpa Rick has type 2 diabetes and just had to have his foot amputated recently. Their daughter Stella, just 4 years old, has type 1 diabetes and has to have her finger pricked dozens of times each day to make sure that her blood sugar level is at safe levels. This disease infiltrates every waking moment of their lives. You know, the Wickmans discovered that Stella was sick on a family trip to the Upper Peninsula of Michigan after a midnight ambulance ride and an admission to a pediatric ICU. Since that day, they really could have sat back and bemoaned their fate, but instead they've really thrown themselves into helping Stella and the many children like her across the country by championing the Juvenile Diabetes Research Foundation of Western Wisconsin. They also carry the torch of another Wisconsin hero, Jesse Alswager. Jesse traveled extensively in his young life, educating others about diabetes. He even testified before a panel here in Congress in support of stem cell research. Jesse died due to complications of juvenile diabetes in February of this year at age 13, but his legacy clearly lives on. In my hometown at the University of Wisconsin, the progress towards better treatment is real. An FDA-approved clinical trial is currently underway for the use of adult stem cells in the treatment of type 1 diabetes. This study is co-sponsored jointly by Osiris Therapeutics and the Juvenile Diabetes Research Foundation. Researchers are specifically targeting newly diagnosed type 1 diabetes patients who still have some functioning beta cells left. An infusion of targeted stem cell therapy could stop the immune destruction and preserve individuals' remaining ability to make insulin. Perhaps the most exciting news for both the Wickmans and researchers in the district that I represent is the passage of the comprehensive health care reform legislation earlier this year. This year, the bill bans insurers from citing pre-existing conditions as a reason to refuse to insure children in America and to ensure that a child like Stella will never be without health care coverage. And this year, that piece of legislation invests $126 million through the new Prevention and Public Health Fund to help create the necessary infrastructure to prevent, detect, and manage chronic diseases like diabetes. Now, clearly, much work remains to be done. So as we work to implement this legislation, we must remember the toll that diabetes takes on our families and on our healthcare system. But we must also work to improve and expand existing federal programs that are making a difference today. And I'm glad that our witnesses are here to help inform that process. Thank you, Mr. Chairman, and thank you again to our witnesses.
Thank you, and I think that concludes our members' opening statements. So we'll now move to our witnesses. Let me introduce and, well, first welcome you both and introduce the two of you. On my left is Dr. Judith Fradkin, who is Director of the Division of Diabetes and Endocrinology and Metabolic Diseases at the National Institute of Diabetes and Digestive and Kidney Diseases at the National Institutes of Health. Fradkin, did I pronounce that properly? Okay. And then is Ann Albright, who is Director of the Division of Diabetes Translation of the Centers for Disease Control and Prevention. And thank you both for being here. I think you know the drill, 5-minute speeches. And then if you want to submit additional written comments, you can. And I'll start with Dr. Albright.
Mr. Chairman, Mr. Shimkus, and distinguished members of the subcommittee, thank you for the opportunity to participate in the hearing. I am Dr. Ann Albright. I'm the Director of the Diabetes Division at CDC. I'm trained as an exercise scientist and nutritionist, but I also have lived with type 1 diabetes for 42 years. The Diabetes Division at CDC translates the science of diabetes into practical strategies to control and prevent diabetes in the U.S. population. And I'll be describing some of our work in surveillance to define and monitor diabetes, the reduction of the risk factors, the prevention of type 2 diabetes, and management of this disease. The ability to identify and the magnitude of a problem through ongoing surveillance is a foundation of CDC's work. CDC developed and maintains the National Diabetes Surveillance System. It's the world's first system for monitoring diabetes. It relies on national and state-based household, telephone, and hospital-based surveys, vital statistics to monitor trends in diabetes. In the last 2 years, CDC has developed a methodology to estimate levels of diabetes and obesity at the county level, providing policymakers and communities with new information to guide programming and resource allocation. CDC, in collaboration with NIH, has also initiated the largest major surveillance system to quantify and track type 1 and type 2 diabetes in those under 20 years of age, called Search for Diabetes in Youth. Among other things, Search allows us to clarify the degree to which type 2 diabetes is affecting youth of different racial and ethnic backgrounds. Findings from our national surveillance system document several increases or successes in the public health response to diabetes over the past decade, but have also revealed areas of major concern and continuing threats to the public's health. Rates of blood glucose being out of control, amputations, and end-stage renal disease among adults have declined. However, considerable variation and disparities in diabetes care and outcomes remain. CDC does work to impact and improve outcomes for women with and at risk for gestational diabetes. In collaboration with the National Association of Chronic Disease Directors and the Agency for Healthcare Research and Quality, we have established a 5-state collaboration to identify, catalog, and validate routinely collected data about gestational diabetes, identify gaps in documenting prevalence, and determine implications for care. Our greatest concern, though, is the continued increase in the rate of new cases of diabetes. This is evident in virtually all segments of society. This continued increase in the rate of development of new cases is unfortunately negating many of the successes that clinical and public health efforts have achieved in reducing the rates of complications. The continued increase in diabetes incidence calls for a comprehensive implementation of a diabetes prevention strategy. So CDC is engaged in risk reduction efforts on multiple levels, including focus on obesity for the general population, but the diabetes division focuses on those at highest risk for diabetes. So these are very complementary efforts. And in fact, we have focused much of our work in the Native American community, helping many members achieve vouchers for nutrition foods, particularly fruits and vegetables. And the use of those vouchers has been in excess of 50%. So a very tangible, concrete example of a way to reduce those risk factors. Based on the findings of the NIH-led Diabetes Prevention Program clinical trial, CDC is now actually translating those findings into practice. We are able to do this with our partners. At the top of the leading role is the YMCA of USA and United Health Group, and we're able to offer this for about $250 to $300 a person. This is the first time ever that a private health insurer has joined forces with a national community-based organization to deliver this work. And we're focusing on training the workforce, on recognizing those programs for quality assurance, for actually investing in delivery of the programs, and for health marketing so people know where to go and how to get those programs. We're also preventing complications of diabetes, and we have research trials that we've been doing, the Triad study. We're taking those findings and we're working with our state-based diabetes prevention and control programs to actually put those into practice and change what healthcare systems are actually delivering as a result of that study. I want to just close with 2 new projects that we have going on that are exciting. And one is the National Program to Eliminate Diabetes-Related Disparities in Vulnerable Populations. We will now be funding 6 organizations that will focus on reducing the mortality and premature mortality and morbidity. And we will be helping this by helping these communities to organize, plan, and implement effective strategies. And finally, we'll also be initiating a new platform of research studies to examine the impact of population-targeted policies emanating from health systems, business and community organizations, and the governments. So several steps have been taken to stem the diabetes epidemic. Work in risk factor reduction must continue so fewer people develop prediabetes. The programs and policies for obesity and prevention and control are critical. There is a critical need for effective programs that prevent people with prediabetes from developing the disease, and the first steps have been taken in the form of the National Diabetes Prevention Program. The complications of diabetes have a very high cost in terms of dollars and human suffering, and while improvements have been made, much work remains to be done, especially in those vulnerable populations. Thank you.
Thank you, Dr. Albright. Dr. Fradkin.
Thank you, Mr. Chairman and members of the subcommittee. And I also want to thank you for your congratulations on our 60th anniversary, and particularly to thank Congresswoman DeGette and Mr. Space and Mr. Green, who actually participated in our celebratory breakfast. And Ms. DeGette in particular made some remarkably inspiring remarks at that event, and I want to thank her. I'm also very pleased to testify with Dr. Albright because our 2 agencies work so effectively together on multiple efforts to combat diabetes, including our National Diabetes Education Program, which is co-led by the 2 agencies. On behalf of NIDDK and the NIH, I'm pleased to report that we are vigorously pursuing research on diabetes and its complications. And today I would like to tell you about some of that NIH-supported research, including research supported by the Special Statutory Program for Type 1 Diabetes Research, which is administered by NIDDK and has resulted in many scientific advances that are improving the health and quality of life of people with diabetes. A parallel funding stream, the Special Diabetes Program for Indians, is administered by the Indian Health Service and has led to substantial improvements in diabetes care in American Indians. Mr. Chairman, the need to pursue research on prevention, treatment, and cure of diabetes is greater than ever because the rates of several types of diabetes are rising. The good news is that we've made tremendous progress in recent years, which has led to improvements in survival and quality of life for people with diabetes. For example, now thanks to continuous glucose monitoring technology, some parents of young children with type 1 diabetes can sleep through the night without having to rise repeatedly to check their child's blood glucose level. The device measures glucose every several minutes and sounds an alarm if the levels are too high or too low. A technological peace of mind allowing parents to sleep more soundly. Because genetic and antibody tests can predict with great accuracy which children will develop type 1 diabetes, we can now test prevention strategies and are doing so. To find new approaches to prevention, we launched the TEDdy study. TEDdy researchers screened over 400,000 newborns to find 8,000 who had genes that put them for particularly high risk of type 1 diabetes. Those children are now enrolled in the study and are being followed until age 15 with a goal of identifying environmental triggers of type 1 diabetes. For example, if we could find an infectious trigger, we might develop a vaccine to prevent the disease. To date, the number of children who have developed autoimmunity and type 1 diabetes are exactly as predicted in this study, showcasing the tremendous power of these predictive tests. We can prevent or delay the development of type 2 diabetes in people at high risk for disease, as demonstrated by the NIDDK-led Landmark Diabetes Prevention Program clinical trial that Dr. Albright mentioned. A modest amount of weight loss through diet changes and moderate exercise substantially reduced the occurrence of type 2 diabetes at 3 years and now in the most recent report at 10 years after enrollment in the trial. This intervention worked in all the ethnic and racial groups studied, in both men and in women with a history of gestational diabetes. Building on this success, NIDDK supports research to translate these results to people who can benefit from them. For example, just this week, NIDDK-supported scientists announced exciting results from research in which community health workers effectively delivered a group-based lifestyle intervention to people at high risk for type 2 diabetes. At 1 year, the participants lost as much weight as was observed in the diabetes prevention program, suggesting that this approach may be a low-cost way to reach Americans. Another NIDDK-supported pilot study is already having a far-reaching impact. Researchers successfully utilized local YMCAs to deliver a lower-cost, group-based DPP lifestyle intervention. And Dr. Albright has provided information about how the CDC is building on the results of this NIDDK-supported research to improve the public health by implementing a national diabetes prevention program. Diabetes during pregnancy brings risk to mother and child. Because of the NIH-supported hyperglycemia and adverse pregnancy outcome study, we now have precise information on what blood glucose levels should be during pregnancy to avoid complications near birth. These are just a few examples of how far we've come in recent years through vigorous supportive research toward increasing knowledge about diabetes and improving the health of people with diabetes. However, much work remains to be done to curb the diabetes epidemic. For example, it's critical to move beyond continuous glucose monitoring technology and link glucose monitoring to insulin delivery to create the so-called artificial pancreas. This technology could help patients achieve blood glucose control that has been shown to reduce complications and also alleviate the burden of self-care. Now that we have thousands of samples collected through the TEDdy study, it's vital to use new and emerging technology to analyze those samples and identify an environmental trigger of type 1 diabetes. Building on the success of the many new available therapies for type 2 diabetes, comparative effectiveness research can help inform doctors' decisions about what medications to prescribe for their patients and when. Loss of the insulin-producing beta cells underlies both type 1 and type 2 diabetes. Research through NIDDK's Beta Cell Biology Consortium may develop new approaches to treatment by providing insights on how to reprogram cells to become insulin-producing cells, stimulate beta cell replication, or replace lost beta cell function with cells derived from stem cells. Complementing these efforts, clinical research can provide information on how best to preserve beta cell function in people newly diagnosed with type 1 or type 2 diabetes. Perhaps most important to combating the diabetes epidemic is reversing the trend of both type 1 and type 2 diabetes occurring at younger ages. because earlier disease onset means earlier development of complications and premature mortality. For women, earlier development of diabetes also endangers her offspring. The intrauterine environment plays an important role not only in problems at the time of birth, but also in the future development of diabetes and obesity, a finding observed among the Pima Indians in Arizona. Thus, it is critical to pursue research to break the vicious cycle of ever-growing rates of diabetes by preventing or mitigating the effects of diabetes and obesity during the childbearing years and pregnancy. Implementing research findings into clinical practice had led to reductions in rates of heart disease, kidney failure, and blindness in people with diabetes. By building on recent advances in diabetes research, we are poised to realize even greater improvements in health and quality of life for people with diabetes. We have come far, but we must go farther. Thank you, Mr. Chairman, for your leadership in calling this hearing to focus attention on the problem and for your continued support of NIH research.
Thank you, Dr. Fradkin. Now we're going to have questions from the members of the subcommittee, and I'll start with myself for 5 minutes. As you both know, the diabetes, I guess it's mellitus, interagency coordinating committee is in the midst of finalizing a diabetes research strategic plan. It's the first comprehensive research plan to be released in several years. I understand it's going to describe the future direction for 10 major diabetes research areas. And Dr. Fradkin, if I could start with you, can you briefly summarize the major focus areas of this report? And then I was going to ask Dr. Albright. She identifies the increasing rate of new diabetes cases as an area of great concern for C2C. So how do you think that plan will help stem the diabetes epidemic? I'll start with Dr. Fradkin.
Thank you. So NIDDK is pleased to chair the DMICC, which includes participation from CDC and multiple agencies across HHS and throughout the government, and really serves as a very effective organization to bring us together to share information and develop plans. So we have developed, with the help of over 100 external researchers, chapters focusing on each of 11 critical opportunities. And these range from very basic areas such as autoimmunity and the beta cell function that I was telling you about, to needs with regard to comparative effectiveness research and translational research to build translation from clinical research into translational research. And we have identified a number of opportunities for important clinical trials that we would like to undertake if funds are available, as well as some key opportunities utilizing new genomics, proteomics technologies to try to elucidate the basis of diabetes so that we can develop new strategies for prevention and cure.
All right, thanks. Dr. Albright, as I mentioned, how is this new plan going to stem the diabetes epidemic, looking at the rate of new diabetes cases?
There certainly is continued research that needs to be done in developing ways to reduce the onset of diabetes in those that have prediabetes and reducing the risk factors so people don't even enter into the world of prediabetes. So particularly the trend, there will be certainly chapters in this plan that will help with those more basic biologic mechanistic work, which is critical. But importantly, this plan also includes a chapter on translational research, and that's an area that CDC and NIH and others share. We both have a role to play in the translation of the basic science into practice. So there will be questions and guidance in that chapter for how to identify those areas that are real world, in which you take what we learn in a laboratory or in a contained setting, and now you've got to take it out to the real world. So it's important that we have studies that allow us to make those transitions. And then certainly from CDC's perspective, we then take that information and try to scale it and sustain it and be sure that there's a much broader reach. Otherwise, the discoveries that we made end up with a very limited reach, and that's not effective for the investment in research. We need to be sure that we get it out to as many people as we possibly can.
All right. Dr. Robert, let me ask you this. You talked about, trying to promote fresh vegetables, fresh fruit, that type of thing. I actually am still the vice chair of the Native American Caucus, and I've taken an interest in, diabetes as pertains to Native Americans in particular, and also in urban areas. And I've always felt that, the biggest problem is, not having access to fresh fruits and vegetables. I know that I remember when I went to the Tohoto O'odham reservation years ago, and they were a desert people that relied on just nuts and fruits and things they gather in the desert, and all of a sudden they're eating processed cheese and tacos and all this kind of stuff, and I know that they've made an effort there to try to go back to some of the subsistence agriculture, but it's often difficult for people, like I know I take my kids to McDonald's. One day I was at McDonald's, and I just, McDonald's is now starting to offer like salads and fruits and different things that are better. But if you stand there for half an hour, nobody orders any of that. They still order the burgers and everything. So how do you promote this effectively? And also, is there alternatives? Like, some people have suggested that maybe use dietary supplements, vitamins, because if people aren't going to eat the fresh fruits and vegetables, there's some other way to supplement their diet, through vitamins or whatever. I don't know. It just seems like even though there are a lot of people out there trying to promote the fresh fruits and everything, that we continue to lose the battle, not just amongst Native Americans, but just in general. I mean, I know it's sort of a comment, but if you could just, how do we get there? And are there alternatives like supplements that can be used instead?
I think that some of the things that we are trying that have an evidence basis behind them, and that's first important, that what we do try has an evidence basis behind it. I think part of the challenge is that we haven't been able to implement these on a large enough scale to have the kind of impact. We do have to change the culture and change the environment so that the healthier choice is the easier choice for people. And that can have to do with pricing strategies and other kinds of things that make it easier. So it's availability, both from a geographic, you don't have to hike 10 miles to get an orange, and you can reach right next to you and get a 52-ounce soda. So we've really got to make access to those things easier. That can be supported by policies and by pricing, other sorts of things that may help with that. And it is going to require a culture change. As far as supplements, they may have a role to play if people are not getting adequate nutrition, but really our major challenge is that people are over-consuming calories. So we do have to consider ways to reduce caloric consumption, and that's what's resulting in the obesity epidemic, and increase the physical activity opportunities, which again is another situation where people need to have safer places to be physically active and know what they can do to improve their health. So while there certainly may be a role for supplements and vitamins and minerals, as a dietitian, I often recommend that people are taking those, but they're not a replacement or an answer for reducing caloric intake and increasing physical activity.
Thank you very much. Mr. Shimkus.
Thank you, Mr. Chairman. I have to continue my role as the burr underneath the saddle of the majority and loyal opposition sometimes. But I need to stand up for McDonald's and understand that the market, if they're not making any profit off those salads, they just wouldn't be selling them.
But they don't sell that many.
But they must be selling enough to keep it on the menu board, I think.
Maybe that's when I'm with my son. He never got
My son used to get the apples over the fries, but now he's moving. He's older. He is moving to the fries now. But that's a real issue. I mean, they wouldn't. They are marketing and they are selling, and if they weren't, they're doing it for the bottom line. But it's an educational aspect. And so when parents are taking their kids in, the parents can also choose healthy. They can set the example for the kids. But I just wanted to put the aside thing. And I also want to put down the first of the health care laws, $569 billion in tax increases starts today with the $2.7 billion tax on tanning services. So just got a little blurb on that and wanted to put that on the record. We can celebrate. Now this is more in line with your visit here, and I do appreciate it. And it's a little technical, so I got to read some of this stuff. You all, CDC and NIH through this section shows the positive benefits of lifestyle intervention, diet, and physical exercise to individuals with type 2 diabetes. Plus, it has been known that the diet plays a major role in treatment and management of type 1 diabetes, and we were talking about that. In fact, insulin's effectiveness requires diet interventions to manage diabetes and slow the progression of diabetes comorbidities, primarily cardiovascular, kidney, and eye complications. Again, something that you were just referring to, Mr. Chairman. So this is a question directing about the registered dietitians who provide medical nutrition therapy, which for a decade since the Benefits Improvement Protection Act, BIPA, as a lot of us like to will say, passed, has been a Medicare Part B covered intervention for diabetes, chronic kidney disease. Under the health care law, the Affordable Care Act states that co-payment and deductible fees are waived for the prevention interventions recommended by the U.S. Preventative Services Task Force with a grade A or B. CMS recently released rules for Section 4104. The medical nutrition therapy was given a grade B. So the U.S. Preventative Services Task Force recommends intensive behavioral diet counseling for cardiovascular and other diet-related chronic diseases. Does CDC believe diet interventions for cardiovascular risk factors such as high blood pressure and high cholesterol for pre-diabetes and other diet-related chronic diseases should be included with diabetes and chronic kidney disease in Medicare Part B medical nutrition therapy? Whew. I know it's a lot, and I had to read it. So, and if this is too big and voluminous, if you could respond in writing or get back to us on that, unless you know the answer.
Sure. I can't speak to the specific official position of our agency. What I would offer, though, is to think about those services that you're describing, which are education and counseling. Those are important services. They will have limited impact if they're not undergirded and supported by other interventions that focus on making the opportunities for people easier to get to, so that the advice they get from their dietitian, and I advise patients as a dietitian, they have to go home to their settings. And if those do not support easier opportunities to get those healthy foods and to participate in physical activity, it makes it more difficult to implement the advice that they're being given by their registered dietitian, whether it's for hypertension or for diabetes. So there are other opportunities to help support that education and counseling so that it can actually have the best impact it could possibly have. But it does need to be supported by these other options and other sorts of things that allow people to make that choice, the healthy choice, much easier for them to make.
And if I may, has a common fund which was established in the NIH reauthorization law been used to coordinate diabetes research across NIH? And Dr. Fradkin, do you know?
So the common fund is actually focused on things that are of broad interest and are not disease specific, with the idea that it's, for example, developing new technologies that will be applied to diabetes. But over half of the institutes, in fact, the great majority of the institutions that are at NIH do participate in diabetes wellness interagency coordination, which is the major coordinating function. Can I just speak to your previous...
Oh, please. Yeah, if the chairman will allow. Thank you, Mr. Chairman. Thank you.
Thank you, Mr. Shimkus. Next is the gentlewoman from Colorado, Ms. DeGette.
Thank you. Dr. Fradkin, my first questions nicely piggyback on Mr. Shimkus's question, because one of the big concerns of the Diabetes Caucus for a long time has been the disparities between minority populations like African Americans, Latinos, and American Indians and Alaska Natives and Anglos. And we're not really sure why those disparities exist, other than a combination of factors of health access, community, environment, genetics. So I'm wondering if you can talk a little bit more about any ongoing research by NIH to address the cause of the disparities, because until we find out the cause, we can't really address how to deal with it.
So first of all, we make a big effort to include minorities in all of our clinical research, and in fact to overrepresent minorities because they are disproportionately affected by diabetes. And in a study such as the Diabetes Prevention Program, the interventions work just as well in minority participants as in non-minority participants. But we do see some differences. So, for example, there have been some researchers recently, for example, suggested that African Americans may have higher hemoglobin A1C values at the same level of glucose values.
Right.
We need more research to look at that, but if that's the case, what it means is that they aren't necessarily getting worse glucose control, but it's the measure of the glucose control that could
Right, which means you're going to have different therapies for those groups. And then we have some groups, like the Pima Indians we were talking about earlier, where they have a huge percentage of their populations with type 2 diabetes, and it could be not necessarily those groups' dietary habits or exercise habits are that much worse than a comparable other population, but that there's some kind of genetic propensity or something else that we could use. Is that right?
Absolutely.
Yeah.
So, most of the studies that have up to now been done in terms of genetics of type 2 diabetes have looked at Caucasian and largely European populations, and the NIDDK just established a very major genetic consortium to look specifically at genes for type 2 diabetes.
And just for the commercial portion of my questioning, we have this minority disparities legislation, which is attempted to deal with this exact issue. And Dr. Christensen has been a huge help, and some of the other caucuses, Mr. Chairman. So we should really look at that bill too as we move along. I want to ask Dr. Albright, you very briefly about this new report that came out from the Robert Wood Johnson Foundation this week, and unfortunately it's called F is for Fat, and it says that the intensity, the rate of obesity continues to increase in 2010, particularly in the Hispanic and African American subpopulations, and this is despite all of CDC's public health campaigns to improve diet choices and activities and everything else. I'm wondering what CDC's strategy is to try to reverse this trend. I know CDC's been working assiduously on it, but it just seems every time we get one of these reports, it's worse and worse. My state of Colorado is almost always the best state, but that doesn't mean it's good, because it just means that the rate of obesity is lower than other places. It doesn't mean people aren't obese. I'm wondering if you can talk about how we can ramp up our efforts to reverse these trends.
Certainly a significant issue, and one that's going to require a multi-pronged approach. I think that's one of the things we all have to remember, is that there isn't a simple single answer for this. It is multifactorial. Other divisions within CDC and other agencies in the federal government are certainly tackling and taking on obesity, particularly working on childhood obesity, so starting early in life and trying to change those habits early in life. They're also working on things related to adult obesity prevention and treatment issues. Much of the focus is turning toward policies and changing the built environment that will help with that. There will need to be some time in order to determine the impact of those broader changes in policy that should have a much bigger impact on a larger segment of the population.
Thank you. One last question for you, Dr. Fradkin. Going back to the special diabetes funding that we're trying to get reauthorized, what benefits, if any, does the multi-year funding stream in that program provide to the ability to fund the most promising research in the field, and how important is that multi-funding aspect of the special diabetes program?
Let me give you an example of one thing that we did with this special funding that absolutely required multi-year funding. We created a program for career development, research career development for researchers studying childhood diabetes. So we gave funds to the institutions that had very, very strong programs in pediatric diabetes research, which enabled them to recruit in promising new investigators with the promise of 5 years of career support. And I can tell you that some of the people supported through that program have already made tremendous contributions. So, for example, at Yale, one of the investigators who was supported through that program has already got NIH funding and is working on trying to close the loop. And in fact, 3 out of 4 of the people supported at Yale are now junior faculty there. We had to stop that program because we don't have 5 years of funding remaining. And so as a result, we couldn't offer people 5 years of career development support. That's just a specific kind of an example, but I think it kind of gives the flavor of why it is important. And many of the things that we're doing, like Teddy, where we have to follow kids until they, are 15, just clearly require a sustained stream of funding.
Thank you very much. Thank you, Mr. Chairman.
Thank you. Gentleman from Georgia, Mr. Gingrey.
Thank you, Mr. Chairman. Dr. Fradkin, you were responded to one of my colleagues just a few minutes ago, and this is not an exact quote, but you essentially said, when the United States Preventative Services Task Force gives something a low grade, it often means that it hasn't been well studied. I would like to ask you your opinion in regard to the low grade that the United States Preventative Services Task Force gave regarding screening mammography for women in their 40s to either prevent or early detection of breast cancer. Do you have any thought on that?
I really have not followed screening mammography closely. That's not in my area.
But you are a medical doctor.
So, I think probably the grade that concerns us in particular relates to their grade on screening for identifying people with diabetes and with prediabetes, where the quality of evidence that it would require for them to recommend supporting that would require many, many years, because simply identifying people with diabetes or prediabetes doesn't rise to the status that they require to find something effective. You have to actually
let
show
me
that
pull
you
back just for a
prevent
second, then I'll let you continue. And because the reason I ask you that, I do have some real serious concerns, because you know that in the Patient Protection and Affordable Care Act of 2010, sometimes referred to as Obamacare, that this task force will begin pretty darn soon to not just recommend but to mandate. And I think it's really important that we take a very, very close look at that. But let me go ahead and shift to the area in which you're now involved, of course, and with some 57 million Americans estimated today to have prediabetes, strategies to prevent or delay the progression to type 2 diabetes are critical to stemming the burden of diabetes on patients and our healthcare system. Do you think the existing guidelines sufficiently address the needs of patients with prediabetes, or is it more important or more attention needed to ensure these patients have access to the most appropriate treatment options? My concern being that, we know a lot of people have prediabetes. I think you gave a figure, an astoundingly large figure. But are we doing enough to really prevent them from progressing to full-blown type 2 diabetes?
So I think this is where the kind of joint effort that Dr. Albright and I have been talking about is particularly important. We at NIH are doing research to try to figure out how to most cost-effectively prevent diabetes in those patients. We have a very strong program looking at multiple different ways to achieve prevention, and specifically looking at culturally sensitive approaches, looking at what works best in particular populations. And then CDC and actually it's wonderful to see even private payers, building on the results of our research to try then to create public health programs that give people access to the things that the research has shown was effective. But clearly our research shows that about 90% of people with prediabetes don't even know that they have prediabetes, and most of them are not taking effective steps to try to reduce their risk.
Thank you, Dr. Fradkin. Well, Dr. Albright, again, regarding that, and you mentioned the vast majority of cases of diabetes in the United States today are preventable, and certainly these many people with pre-diabetes. What are the top things that can be done to prevent these cases from progressing?
At this point, the evidence that we have suggests really scaling up and making this National Diabetes Prevention Program widely available to people. We are now offering it. CDC is providing funding to 11 sites. United Health Group is providing it to 6. They've agreed to take over coverage of their beneficiaries. So it's a very good public-private model. We'll get the ball rolling in some of these locations, and the private insurer can take over and continue to reimburse as time goes on. And so that's a nice combination. But we do need to get to more places and get to more locations, particularly harder to reach places. We need more entities that can deliver this in addition to the YMCA USA, who is outstanding, and other additional third-party payers. So we've got the beginning infrastructure there, and it's time now for us to expand that infrastructure and allow it to have reach across the country.
Thank you, Dr. Albright, Dr. Fradkin, and I'll yield back. Thank you both.
Thank you, Mr. Gingrey. Next is the gentlewoman from the Virgin Islands, Ms. Christensen.
Thank you, Mr. Chairman, and I want to thank you both for your testimony and your answers thus far. Dr. Albright, you mentioned working with 5 states and 6 organizations. Do they have a good mix of the population, a good population mix?
Yes,
they didn't mention what states they were. Or.
Yeah, we are not we can't publicly announce them yet because the reviews have just been done, but that's we work to pay special attention to that. We first look for the best applicants. Certainly that's number one, but we are working and always seek to assure a wide representation of states and more territories and Pacific jurisdictions as well. We do provide funding to all of the U.S. affiliated territories, so we are eager to have them involved as well.
I just wanted to make sure that there was diversity in
yes,
represented in those states and organizations. Both of you have talked about the importance of the social and economic determinants of health, and certainly that's some of the reason why we haven't been able to make the impact in the African American, Native American, Hispanic communities. I've been supporting having a executive order similar to the one that President Clinton had issued back in '98, I guess, around environmental justice, requiring that all agencies of government, all the departments, do health impact assessments on their policies and programs, and actually go beyond that to try to address some of the social and economic environmental issues through their policies. Do you think that is that something that you could both support? Because it seems as though we're not going to make any progress as long as people live in food deserts, have all of the socio and economic and environmental barriers to improving their health.
I can certainly say that CDC's focus is growing in that area under the leadership of our agency director, Dr. Tom Frieden. We certainly are focused on policies and environmental changes that will support that, and really one of the themes at CDC is really seeking health in all policies.
Yes,
so that's
basically.
Yes, it is going to take, because it's so multifactorial of a problem, we do have to consider and evaluate the kinds of things that we are doing to try to make an inroads in these very broad areas in our society. But it's critical that we do investigate them and find solutions within these multiple areas.
Maybe I could just speak to one specific investigation that we have done in this regard that we actually just reported the results on this past week, and that was a huge study in which we looked at the environment in 42 middle schools, focusing on schools that predominantly served minority and low-income students. 50% were Hispanic, over 20% were African American, most of them were on free or reduced lunch. And we looked in those schools at changing the food services, increasing physical activity, and also promoting behavioral change. And we got some positive results. We didn't get everywhere we wanted to be, but we saw reductions in obesity in the kids who started overweight or obese, which was half the kids in these schools were overweight or obese, and those children had reduced obesity as a result of this intervention, decreased waist circumference, decreased levels of insulin. So some positive impacts on risk factors for type 2 diabetes. And this is the kind of societal intervention that I think, NIH likes to, do research to, test. And then when we see results from studies like this, then the public health agencies move to try to translate that.
Thank you. I'll yield back, Mr. Chairman.
Thank you. Mr. Space, for 8 minutes.
Thank you, Mr. Chairman, and thank you again for exhibiting your commitment to such an important issue by convening this hearing. Where to begin? Dr. Albright, your testimony, and actually both of your testimony, I think, underlines the increase that we're seeing in all types of diabetes. And your testimony briefly alludes to, and I think some of my colleagues have referenced it very specifically, the cost that this is visiting upon our country. And just doing a little bit of quick math, assuming that we're somewhere north of $200 billion a year now, which I know is probably true. I know the ADA's study from a couple of years ago, 2007, was at $174 billion. That computes to over $500 million a day that this disease is costing our society. And as Ms. Schakowsky pointed out, much of that is a direct governmental expenditure. And to put it in perspective, in 2009 we spent $148 billion on 2 wars in this country. And now we're spending upwards of $200 billion a year dealing with the effects of this one disease that has taken several different forms. Is it a safe assumption that with the increase in incidence of diabetes that these costs will continue to escalate?
Yes, that would be the short answer.
And the much of the cost associated with diabetes consists of treating the complications of diabetes, correct?
They certainly are associated with the cost of treatment. Fortunately, as we've said, there are ways for us now to prevent, and we've been trying to work to get those to be delivered as cost effectively as possible.
So with the delivery of those preventative mechanisms and maintenance mechanisms, in the end you will mitigate the total cost associated with treating the complications that you can prevent or reduce through effective maintenance and treatment. And in the end, dollars spent today will result in a significant decrease in dollars spent tomorrow. Is that a safe statement?
I think there's some little parameters you have to put around there when you are looking at cost effectiveness. You're very right that you do have to look at the time horizon and you have to look at the assumptions. But there certainly are opportunities for us to drive the costs down in treatment and prevention so that we can indeed have more productive citizens who can be contributing to the economy in successful ways. So, yeah, there's certainly benefit to doing that.
If we were to develop a cure for diabetes, and I want to, on the subsequent panels, maybe talk a little bit about how we might better do that. But if just hypothetically, if we were to develop a cure for diabetes, and that cure can take many different forms. It could be an artificial cure like the closed loop system that you've referenced, or it could be a more natural cure, perhaps someday with embryonic stem cell research. If you've got a young person that develops diabetes at the age of 6 or 7 years old, who was diagnosed with type 1, the complications that child is likely to experience as a result of the disease are not likely to manifest themselves for decades, correct?
That's right.
So that by the time that child is 40 or 50 years old, his risk for heart disease, blindness, stroke, kidney disease, amputation is much, much higher than it would be for someone who's not diabetic.
Absolutely.
At that age. What I'm trying to drive at here is the future costs of this disease, as debilitating as they are today, in a society, in a country that can't afford the luxury of $200 billion a year on one disease. As debilitating as these costs are today, can you give us some projection as to where we may be in 20 years or 30 years, given the rather rapid increase in incidence of both type 1 and type 2 diabetes, in the event that we do not see a cure, and we do not see the implementation on a wide scale of some of the measures that you're testifying about today with maintenance? What will be the implications economically to this society in 20 years if we continue to go the way we're going now without massive intervention and maintenance and or cure?
Do you want to start or do you want me to start?
Well, I think obviously the CDC is predicting that 1 in 3 children born today and 1 in 2 minority children born today will develop type 2 diabetes if we don't intervene and change things. But I would like to point out that there are some very real improvements in terms of the prognosis for people with diabetes that have effects on healthcare costs. So because rates of diabetes are increasing so fast, if it weren't for some of the effective things that we're doing to bring down the complications of diabetes, we would be seeing even greater costs than we're seeing today. So, for example, even though rates of end-stage kidney disease, which is a huge expense for Medicare, are going up, the actual proportion of people with diabetes who develop end-stage renal disease is falling. So if we weren't doing those effective interventions, as diabetes is increasing, we would be seeing even greater increase in the cost than we're seeing.
I think this is definitely a combination of this is where we are seeing a greater number of people with diabetes, and that's because as people live longer, as we diagnose them earlier, as we catch them, less people have undiagnosed diabetes. We are going to have a bigger total prevalence or total population. We want to drive that number down by reducing the new cases so that what resources we have can be delivered to effectively manage those people that have the disease, and then hopefully over time, yes, not have a future of 1 in 3 and the devastating complications. So we've got to make headway in preventing all forms of diabetes, in better treating diabetes, because it also is where we will spend the cost. Yes, it does cost to take care of people with the disease. It does cost to prevent, but the opportunity to not have people suffer the ravages of this disease and continue to be productive members of society is a critical piece to be sure we keep in the discussion about the economics of diabetes.
Thank you, Doctor. Thank you, Doctor. I regret that I have no additional time. So
no, that's all right. I mean, I'm glad you don't, because we are going to have a vote. We have 3 votes. So I'm going to try to get on our other 2 people here if we can.
Before you recognize,
yes.
Can I just ask unanimous consent to submit a folder of different statements by different groups about their activities for the record? And this has been cleared with the minority. They've reviewed it.
All right, we'll take a look at it first.
They've seen it.
You have?
Yeah.
Okay. Without objection, so ordered.
Thank you.
And I'm going to try to get in Ms. Schakowsky and Mr. Engel, and then we'll let you go and come back after the votes for the second panel. I recognize the gentlewoman from Illinois.
I think this is a quick question. There's been a lot of recent news about Avandia the drug that's used to treat type 2 diabetes by increasing the body's sensitivity to insulin. 2 new studies released earlier this week add to the body of evidence about the risk of heart attack, stroke, and heart failure among people who take these drugs. And those are, of course, the very things we're trying to prevent with preventing by treating diabetes. The FDA is holding an advisory committee meeting in mid-July where the safety of Avandia will be under review, and I think this is an appropriate action at this time. While the FDA deliberates on the safety and effectiveness of this drug, I wanted to ask about the underlying research and public health implications. Dr. Fradkin, in your professional opinion, what are the implications of the recent studies? And Dr. Albright, if you have anything else to add.
Well, let me just say that there are now multiple different classes of drugs that are available to treat type 2 diabetes as a result of research. And rosiglitazone, Avandia, and pioglitazone are members of one of those classes of drugs. Most of the drugs have been approved based on relatively short-term studies that show that they're effective in reducing glucose. But I think what we really need, and what the strategic plan that the chairman referred to that the DMICC is developing, is what we really need is head-to-head comparisons of the various drugs that are available for treating type 2 diabetes with longer-term time frames, looking not simply at glucose lowering, but looking at what they do over the course of diabetes in terms of heart disease, in terms of weight gain, in terms of quality of life for people, and we don't have those head-to-head comparisons. And so most of the data, like these current studies that you're referring to, are basically analyses of observational studies. They aren't the ideal, rigorous kind of research that you need to answer the question. And the rigorous research is something that we need.
So let me ask you, Dr. Albright, then what advice would you have for people who are taking Avandia right now? Because it appears that not only do we have to reduce the blood sugar, but how we do it is very important. And obviously, more and more research and studies, scientifically based studies, have to be done. But in the meantime, what do we tell them?
Well, our response when we're asked, and we are asked these questions, is that it is critical that people have the discussion with their healthcare professional, because as Dr. Fradkin referenced, there are other treatments. Their particular risks can be very carefully examined and determined. So it's important that people have a conversation with their healthcare provider, because diabetes is a disease where you have to make lots of decisions. And it's imperative that you have a good discussion with your healthcare provider to make those decisions for you as an individual.
Well, all of this really is a humbling reminder that we still have a lot to learn about diabetes, and that we need to do that. So thank you very much. I yield back.
Thank you. Mr. Engel?
Thank you, Mr. Chairman. I'll try to speak very fast. 135,000 women excuse me, are diagnosed with gestational diabetes each year as well. I know that Dr. Burgess spoke about it. He and I have introduced the Gestational Diabetes Act, which is H.R. 5354, and we've got many co-sponsors, and I hope people on this subcommittee will all co-sponsor it in a bipartisan way. And what our act aims to do is lower the incidence of gestational diabetes and prevent women afflicted with this condition and their children from developing type 2 diabetes. And the legislation creates a research advisory committee headed by CDC to develop multi-site gestational diabetes research projects to enhance surveillance, provides demonstration grants to focus on reducing the incidence of gestational diabetes, and expands basic clinical and public health research investigating gestational diabetes and current treatments and therapies. And I ask unanimous consent for my opening statement to appear in the record.
Without objection, so ordered.
Okay, thank you, Mr. Chairman. Let me ask the first Dr. Fradkin. I'll ask each of you one question. First of all, Doctor, congratulations on the NIH, National Institute of Diabetes and Digestive Kidney Disease's 60th anniversary.
Thank you.
It's because of the tremendous support of the National Institute's research toward understanding, preventing, and treating diabetes that we're closer than ever to better fighting and curing the disease. So congratulations. Could you tell me more, please, about the results of the hypoglycemia and adverse pregnancy outcome study? I guess it's the HAPO study. And do you find that expansion of basic clinical and public health research investigating gestational diabetes and obesity during pregnancy, such as our ACT, would be useful to further develop the insights gained from the hypoglycemia and adverse pregnancy outcome study?
I can't speak specifically to the ACT, but I can tell you that I think gestational diabetes is one of the most important problems confronting us in the area of diabetes, because not only does it cause problems at the time of birth for both the mother and the child, increasing rates of cesarean section and injury to the child, but also it puts the mother at increased risk for subsequent diabetes. Our diabetes prevention program showed some very positive results in that regard. But also we have data suggesting that the intrauterine environment puts the offspring at increased risk for diabetes and obesity. So you can imagine the vicious cycle that can occur as type 2 diabetes occurs at younger and younger ages, moving toward people developing gestational diabetes or even type 2 diabetes during their childbearing years. Then the offspring of that pregnancy not only has the genetic risk that it gets from the parents, but also has the increased risk conferred by this adverse metabolic environment that also then increases the risk. And so you can imagine sort of a vicious cycle where rates of diabetes will increase at expanding rates. So this is a cycle that we really need to break. And I think the HAPO study has given us some extremely important information showing that adverse effects of hyperglycemia in pregnancy occur at much lower levels of glucose than we previously appreciated.
Thank you. Very well said. Dr. Albright, you mentioned in your testimony that women with type 2 diabetes are at increased risk for having babies with birth defects, and women with a history of gestational diabetes should receive targeted intervention strategies to prevent type 2 diabetes before they become pregnant, during pregnancy, postpartum, and between. Can you please describe some of the intervention and educational outreach strategies the CDC is undertaking to increase awareness of gestational diabetes and the risks associated with it?
Yes, briefly, we are making special effort in the National Diabetes Prevention Program that we mentioned earlier to really put recruitment efforts and raising the awareness of women of childbearing years and their risk if they've had GDM for developing type 2 diabetes. And special efforts will be made to really try to seek to get them involved in this program. They are a terrific candidate for the National Diabetes Prevention Program. We also, as part of the National Diabetes Education Program that Dr. Fradkin and I have the honor of working on together, we are working on some more gestational diabetes education efforts. We've received some funding from HHS, and NIH will be taking the lead in doing some comparative effectiveness work with our NDEP materials. So we are continuing to work together in that area.
Thank you. And before I yield back, I just want to throw a little accolades to our counsel here to my left, Emily Gibbons. I'm going to thoroughly embarrass her, but she was my long-term legislative director and health person, and Mr. Pallone stole her from me.
With permission.
With permission. And she does marvelous work and has done the work for both of us on gestational diabetes. So now that I've thoroughly embarrassed you, I yield back.
I'll second that. I'll second that. Thank you, Mr. Engel. And thank both of you. This was very helpful. We really appreciate it. And, you know, obviously something that we have to deal with long term, but we appreciate your testimony. And what we're going to do is we're voting now. We have 3 votes. Should take us to approximately 1:30. So if anybody wants to have lunch, we will reconvene at 1:30 and we'll have our second panel. Thank you. Committee stands in recess.
I know. It's funny that they put you there because I was like shocked. I can't too. I think that's funny. So what are we doing? Hey. It's pretty high, but in 21-23.
I know. And I'm like,
Yeah, you can submit. So we have 10 days. We have 10 days. 10 business days. As a general practice.
Yeah, what I was going to say, if you forward us the questions that people were asking, we can in writing, you can write.
Right, and just as a general practice, they have, there's a formal process for submitting questions after the hearing. And members have 10 business days to submit. So we have, like, our office downstairs would compile them and then just send them out.
Okay. Because I do want to make sure if people have questions for him that they get the answers.
Okay. Someone's busy drawing. Are y'all getting lunch down at the cafe?
Well, I've got it.
Yeah, well, yeah, that's the best place to go. So
Right.
we'll look for you.
Oh, I see.
Oh.
All right, nobody's from there. Okay, we'll be there by 5 to 1. Okay, got it.
We're gonna go down to 22107 and go get lunch.
Yeah.
Bring your other bag here.
I would take it.
We're gonna
I don't know if we're gonna get it.
stop
We do have the
And
you?
Good. I'm Lisa Cox with the American Diabetes
Oh,
Association.
okay.
I think we just spoke on the
Okay,
phone. Good to see you.
How are you?
I'm good. I'm good. I'm gonna change out of my
Heels. I don't blame. I do not blame you. Well, I am hungry. Can I go run and get some?
Is there anything else you need from us?
No, I think we're good.
Okay.
I
think it's going well.
Yeah, I think so too. It's it means clearly a topic that we
Yeah,
should
yeah.
care about and everyone cares about.
Oh yeah. Couldn't ask for better attendance.
Yeah.
It's great.
The subcommittee will reconvene, and as I promised, we will begin with our second panel. Let me introduce each of you. First is Chairman Buford Rowland, who is Vice Chairman and Nashville Area Representative for the National Indian Health Board and also Chairman of the Porch Band of Creek Indians. Thank you for being here. Then we have Dr. Robert Goldstein, who is Senior Vice President for Scientific Affairs of the Juvenile Diabetes Research Foundation, and Dr. Robert R. Henry, who is President-elect Medicine and Science for the American Diabetes Association, Professor of Medicine at the University of California Department of Medicine, and Chief of the Section of Endocrinology, Metabolism, and Diabetes at the VA Medical Center in San Diego. I need to mention to the panel that Chairman Rowland is going to testify and then leave because he has to catch a plane in previous commitments, but he will take written questions. And the way we work, as I think you know, we have 5 minutes opening from each of you, and then we take questions, but you can submit additional written statements if you like, and then members may also follow up with some written questions as well. So we'll start with Chairman Rowland. Nice to see you again.
Thank you, Mr. Chairman and members of the subcommittee. I'm Buford Rowland, Chairman of the Porch Band of Creek Indians and Vice Chairman of the National Indian Health Board. I also serve as the co-chair of the Tribal Leaders Diabetes Committee. And
I'm not sure, Chairman, that your mic is on. Is it green?
It's green.
Then you have to bring it a little closer then.
Okay, can you hear
that's
me?
better.
There we go.
Thanks.
Thank you. I'll just begin over. Good afternoon, Mr. Chairman and members of the subcommittee. I'm Buford Rowland, Chairman of the Porch Band of Creek Indians and Vice Chairman of the National Indian Health Board. I also serve as the co-chair of the Tribal Leaders Diabetes Committee, and on a personal note, I have lived with diabetes for the last 6 years. Thank you for inviting NIHB to participate in this important hearing. I apologize, but I must leave early to catch a flight. Today, American Indians and Alaska Natives suffer disproportionately from diabetes. Indian adults are 2 times more likely to have diabetes compared with the non-Hispanic whites. In some tribal communities, more than half of the adults have been diagnosed with diabetes. Sadly, the highest rate of diabetes diagnosis has occurred among our young children and young adults. From 1990 to 2009, young Native people ages 25 to 34 years experienced a 161% increase in diagnosis of type 2 diabetes. In addition, diagnosis of diabetes rose 110% in our teenagers 15 to 19 years old during the same period. Despite these alarming statistics, progress is being made. This progress would not have been possible without the Special Diabetes Program for Indians. Congress created the SDPI in 1997 in the wake of increasing public concern about the burden of diabetes in Native communities. In 1998, the Indian Health Service established the Tribal Leaders Diabetes Committee to provide guidance on SDPI, diabetes, and related chronic diseases. Today, through SDPI, IHS provides funding and support for diabetes prevention and treatment programs, services, and activities to over 450 IHS, tribal and urban Indian SDPI programs. And it is working. Diabetes-related health outcomes have improved significantly in Native communities since the launch of SDPI. For example, there's 11% decrease in the blood sugar level, A1C, in Indian people who have been diagnosed with diabetes. This decrease translates to a 40% reduction in diabetes-related complications such as blindness, kidney failure, nerve disease, and amputations. 16% increase in total cholesterol level, and a decrease of 20% in blood and bad cholesterol. Research has shown that lowering cholesterol levels reduces the risk of developing complications associated with diabetes, such as heart attacks, stroke, or heart failure. 32% decrease of the prevalence of protein in urine and a risk in kidney disease. New cases of diabetes-related dialysis in Indian people decreased 31% between 1999 and 2007, while remaining relatively unchanged in other races. Preventing kidney failure is critical to help people with diabetes avoid needy dialysis or kidney transplants. In addition, SDPI has enabled the IHS tribal and urban Indian programs to provide expanding screening, prevention, and diabetes treatment services, as well as to build a desperately needed infrastructure. The committee should also know that the outcomes of the SDPI and knowledge gained through these scientific-based programs have helped to inform and advance other IHS diabetes programs, such as the Model Diabetes Program established under the Indian Healthcare Improvement Act. The 19 model diabetes programs in the Indian health system have made significant contributions, including state-of-the-art comprehensive clinical diabetes care through a multidisciplinary preventing and treatment approach. The Special Diabetes Program for Indians has been life-saving to people who have diabetes, life-changing to those who have avoided diabetes because of early detection and prevention efforts, and perhaps most importantly, it is helping to ensure a diabetes-free future for our children and future generations. Making real progress in this area and ensuring that future generations will be free of the burden of this disease requires federal and tribal government collaboration. We have shown it can work. Now we need to recommit ourselves, and this hearing is a good first step. On behalf of the National Indian Health Board, thank you for this opportunity to address the subcommittee regarding this important issue. Thank you.
Thank you, Chairman, and thank you. I know that you have to leave, but I do appreciate your testimony, and I want you to know that I speak for myself, but I think I can speak for everyone in saying that, we're particularly conscious of the impact of diabetes on the Native American community and want to help in any way we can to, deal with this epidemic. I appreciate your comments. Dr. Goldstein.
Thank you very much.
Chairman Pallone, Ranking Member Shimkus, and members of the subcommittee, thank you for the opportunity to testify before you today. I'm Robert Goldstein, Senior Vice President of Scientific Affairs for the Juvenile Diabetes Research Foundation. I'm honored to be here today before this distinguished committee with my colleagues from the diabetes community. JDRF is the largest charitable funder and advocate of diabetes research worldwide. Since our founding 40 years ago, by parents of children with type 1 diabetes, JDRF has awarded more than $1.4 billion to diabetes research. Type 1 diabetes, also known as juvenile diabetes, is an autoimmune disease for which there is no cure, at least not yet. It is the second most common chronic disease affecting children. It is growing rapidly, particularly in our youngest children. Diabetes overall costs our nation more than $174 billion a year, and 1 in 3 Medicare dollars is spent on people with the disease. But the good news is that we are moving faster toward a cure for type 1 diabetes than ever before, thanks to a strong federal commitment to diabetes research funding, as well as JDRF's private investment. A key component of the federal investment is the Special Diabetes Program, which provides a critical 35% of NIH funding for type 1 diabetes research and supports the multi-center human clinical trials that are contributing to discovering better treatments. Let me highlight some of the key advances which benefit not only those with type 1 diabetes, but those with type 2 diabetes and other autoimmune diseases. Researchers have discovered ways to slow the autoimmune attack that causes type 1 diabetes. Charlotte Cunningham, a 15-year-old from Maryland, was able to produce her own insulin for 3 years after receiving a drug treatment called anti-CD3, and today is better able to control her blood glucose levels. Great strides have been made in investigating therapies to regenerate and replace insulin-producing cells. Thanks to this research, Ann Seidel DeMerick of Texas and now California, who received an islet transplantation, no longer suffers from frequent low blood sugar episodes, which impacted her ability to care for her young son, who unfortunately also has type 1 diabetes. Researchers have paired continuous glucose monitors with insulin pumps to develop an artificial pancreas to help those with type 1 more easily and accurately control their blood glucose levels. A study recently published in The Lancet found an early artificial pancreas system lowered the risk of low blood sugar emergencies in children and teenagers while they were asleep. Researchers have recently found a way to reverse diabetic eye disease, the leading cause of adult onset blindness. Sally Cartwright, a 66-year-old type 2 patient, can now drive thanks to a treatment combining a drug and laser treatment. As this progress shows, diabetes research is one of the world's most effective public-private partnerships focused on curing a particular disease. Yet despite tremendous advances, there is still much work to be done. On behalf of JDRF and the millions of families affected by diabetes, I thank the committee for its leadership and strong support for the Special Diabetes Program, which is a key element of our continued success. We deeply appreciate your commitment and look forward to continuing to work with you to cure this devastating and costly disease. Thank you again for holding the hearing. I'll be happy to answer questions.
Thank you, Dr. Goldstein. Dr. Henry?
Well, thank you for the opportunity to testify today, and to Chairman Pallone and Ranking Member Shimkus for holding this hearing. I'm pleased to be here on behalf of the American Diabetes Association. My full written testimony has been submitted for the record, and in the 5 minutes I have, I will summarize it. I've just come from the American Diabetes Association's 70th Scientific Sessions Conference in Orlando, Florida, the world's largest diabetes research meeting, where over 14,000 diabetes researchers, providers, and educators gathered to hear and discuss the latest in diabetes research. The CDC has identified diabetes as a disabling, deadly epidemic that is on the rise. Between 1980 and 2007, the prevalence of diabetes has increased by 300%. Its total cost is over $218 billion a year. The association is grateful to the committee for supporting vital HHS diabetes programs, including the NIDDK, CDC's DDT, and the Indian Health Service. Because of this investment, our knowledge of the disease has been expanded, and the critical work towards ending this epidemic can continue. Our efforts have significantly changed the way diabetes is addressed in both the clinical and community settings. Since 1952, more than 4,000 research projects on type 1, type 2 diabetes, and gestational diabetes have been funded by the American Diabetes Association. In 2009, the association awarded $33.55 million in new research support. We strive particularly to bring research from bench to the bedside and swiftly into the hands of patients and care providers. We fund cutting-edge research. Association-funded work developed the first handheld blood glucose meters, a key tool to achieving diabetes control. Currently, our research has found a potential new treatment for diabetic retinopathy, a complication that makes diabetes the #1 cause of adult onset blindness. We value our partnerships with key health organizations, and I'm pleased to point to our continued work with JDRF in the development of an artificial pancreas that holds a promise of revolutionizing diabetes management for type 1 diabetes. We are committed to developing the pipeline of diabetes researchers, including funding younger researchers and more minority investigators to ensure the vitality of future research. We've made great progress, but more has to be done. With this in mind, I want to outline several key next steps in the battle to stop diabetes. More attention must be paid to the pressing needs of special populations, particularly affected by the diabetes epidemic, including minority populations. We remain steadfast in our efforts to support research that addresses these disparities. H.R. 3668, sponsored by Representatives Diana DeGette and Mike Castle, helps address this issue by renewing the Special Diabetes Program. SDP programs in American Indians and American Native communities and SDP-funded Type 1 research are highly successful. The program expires in 2011, and I urge Congress to pass this legislation soon so this work can continue. H.R. 1995, the Eliminating Disparities in Diabetes Prevention Access and Care Act, also seeks to address racial and ethnic health disparities related to diabetes. We thank Representative DeGette, again, for introducing this bill, and Representative Donna Christensen for including it in the Tri-Caucus's health disparities legislation. We also must increase efforts to prevent and treat gestational diabetes. Representatives Elliot Engel and Michael Burgess have sponsored H.R. 5354, the Gestational Diabetes Act, which aims to lower the incidence of gestational diabetes in order to protect mother and baby and prevent future cases of type 2 diabetes. Our collective fight to stop diabetes must be continued. Your leadership in combating this growing epidemic is absolutely essential. Thank you for your commitment to the diabetes community, and it would be my pleasure to answer any questions you might have on these important issues. Thank you again.
Thank you, Dr. Henry. We're going to have questions from the panel, and I'll start with myself. Dr. Goldstein, can you explain how the promising research you're doing with the NIH and the private sector on initiatives like the continuous glucose monitor, artificial pancreas was mentioned several times, how these are going to better control diabetes and the diseases associated costs and complications, because we know the costs are unbelievable. 1 out of 3 Medicare dollars is spent on diabetes.
Mr. Chairman,
And I asked Dr. Henry to comment as well.
The NIH-supported DCCT study in 1993 for the first time demonstrated that high-quality, tight control of the blood sugar variations resulted in improvements. Over time, those patients have now been studied for 20 years, and the complication rates have just dropped from very large numbers to 15 and 20% numbers, so that the reduction in complication rate from just exerting tight control has been enormous. With the continuous glucose monitors, we've upped the ante because patients can now achieve high-quality tight control with lower risk for getting blood sugars that are too low, and with just an improvement in the overall quality of life because they don't have to concern themselves so much with measuring blood sugars 6, 7, 8 times a day. So the JDRF supported a study that was published a couple of years ago that showed you could drive the hemoglobin A1C down, which is directly correlated to reduction in complication rates. And we're in the phase now where we're working with everybody we can find, industry, other organizations, to implement high-quality, tight control in as many patient populations as possible, ranging from children, adolescents, pregnancy. We're just beginning to start there. And the idea is, while we're waiting for a cure, we want people to implement very high-quality control of their diabetes so that they'll be in good enough health when the cure does appear.
All right, Dr. Henry, you can answer that. Also, I wanted to issue a question, too, separately about the association's role as a government partner and how you strike a balance in addressing the needs of the different types of diabetes, type 1, type 2, gestational. So if you want to follow up on him and then get into that.
Well, I would say I agree with everything that Dr. Goldstein has stated, and clearly the goal for an artificial pancreas is to make it easier to be able to regulate the blood glucose within the normal limits. And as you heard, complications are minimal or minimized by good glycemic control, particularly low blood sugars, hypoglycemia, which can have devastating consequences, as well as persistent high blood sugars, which leads to complications. So these can be minimized by a feedback between understanding the blood glucose levels and injections of insulin. The other thing that we found that the DCT research, the long-term, funded by the NIDDK data showed is that there were a legacy effect, so that controlling diabetic patients today with type 1 diabetes had effects on cardiovascular disease, beneficial effects on cardiovascular disease 10 years later. So that there was just short-term, the study lasted for several years, but even 10 years later there were significant benefits. So I think that it emphasizes that good control now will not only reduce the long-term consequences, but they will have sustained benefits for many, many years. In terms of the second question, can I ask you to repeat that?
I may forego that because I did want to ask something else. I know, I'm so interested in the issue as it affects the Native Americans, and Chairman Rowland left. But I just wanted to ask, he gave me the impression that we really were getting a handle on diabetes amongst American Indians. Is that? I mean, obviously there is some success, but my recollection, just talking to different tribes, is that the incidence of diabetes is still on the increase, and particularly amongst younger people. How do I reconcile that with what he said? I mean, he's not here, so it's difficult, but.
Sure, I'd be happy to. I think you're correct that the prevalence continues to rise in the Indian and the native Alaskan population. However, we're doing a better job of taking control of those people, so they're lasting, they're living longer, but we're doing a better job of preventing the complications.
So more people are still contracting diabetes, but you're able to control it and make them live longer.
And many of the complications of the nerves and of the kidneys and the eyes, we've made substantial progress in reducing those. So while there has been significant progress, as he states, the prevalence of the disease does continue to rise, though.
Okay. Thank you very much. Mr. Shimkus?
Thank you, Mr. Chairman. And I want to, Dr. Goldstein and Dr. Henry, you can chime in too. In your statement, you talked about the islet technology and use. And I know in the early part of the decade, there was widespread media reports on the promise of this, especially those with type 1 diabetes, and healthfully living. The hope was that they would be able to live without daily injections of insulin. And you briefly mentioned one case. What is the promise of the islet use?
So the pancreatic islet transplantation study you're referring to, which was reported from Canada in the year 2000, was widely heralded and adopted. And NIH studied it, and the initial promise probably exceeded what could be delivered. But the long-term promise is quite interesting. So if we prepare islets from a cadaveric donor pancreas and transplant that into somebody who's got relatively severe disease, typically with what's called hypoglycemia unawareness, where they don't know that they're getting low blood sugars and could be prone to seizures and that sort of thing. The islet transplant actually reverses the hypoglycemia unawareness, even if you still have to take insulin. And for those patients who have had to continue to take insulin, the quality of their treatment has improved so much, and two complications have begun to reverse, one in the eyes and one in the nerves. So it's had a important conceptual effect, which we call a proof of concept, that cell therapy or replacement therapy can actually work. That kind of replacement therapy requiring lifelong immunosuppression to prevent graft rejection is not exactly what we'd like to give to our children. So we need improvements on that. And hopefully this will lead the way towards the next generation of productivity.
Great. Dr. Henry, you want to add anything to that?
Well, I would only say that there was a large number of symposia at this recent ADA meeting in Orlando, which addressed islet cell rejection and techniques to prevent rejection, techniques to stimulate other cells to become islet cells. And so I think that this is a very sort of stimulating area of research that is currently ongoing.
Dr. Goldstein, you mentioned also in your statement, not the written, but when you were talking, anti-CD3. Can you elaborate on that?
Can I divert your attention for 30 seconds?
It happens all the time. So,
Mr. Burgess, Dr. Burgess talked about a soldier who was injured by blast injury, and was losing his pancreas surgically to save his life in other ways. That pancreas went to one of the islet transplantation programs in Miami. They recovered the islets from this soldier's damaged pancreas, sent them to Walter Reed. They were transplanted back. And he now has function and doesn't have diabetes because of that traumatic event. That couldn't have happened if there weren't a facility that understood how to prepare those islets. Let me tell you about anti-CD3 in a moment, please. So, type 1 diabetes is an autoimmune disease where the immune system reacts in an abnormal way. If we can stop that autoimmune response, we presumably can stop the attack on the insulin-producing cells. Anti-CD3 is a monoclonal antibody which blocks the autoantibody response. If you give it to Charlotte Cunningham within 4 or 5 weeks of the time she got the disease and block that autoimmune response, her body stops destroying insulin-secreting cells. And she keeps them functional now almost up to 4 years.
Great. I mean, that's always good news on hopefully future uses. And I'll just end with this. And Dr. Goldstein, I know that the charity JDRF has a good ratio of money spent out versus overhead costs. And I was going to ask questions, but I'll just place that on the record because we do know that you're good stewards of the donations. And I put on the record a family who, especially since I got elected to Congress, has just been all over me. And they have two. Their youngest boy was Kevin Covarrubias. He's been up here for the Congress years ago. And what was challenging and is that he as a young boy was identified. Then his brother, who was older, only was identified after in his late teens, like 18 or 19 years old, which I guess had Ryan appreciate what Kevin went through for all those years. So my hats off to the Covarrubias family for doing the work in the field too. And I yield back, Mr. Chairman. Thank you.
Thank you. Ms. DeGette.
Thank you, Mr. Chairman, and I want to thank both of you for coming and for all of the work of your organizations. I was getting a lot of thanks up here, but really it's you and your partners at the federal agencies that are doing all the work, and all of the families too. Whenever Mr. Space and Ms. Capps and the chairman and I and everybody will tell you that that when even Mr. Shimkus will tell you that when these families come up to the Hill to testify and to talk to members, it's the most powerful evidence that we get up here. So thank you for that. I want to follow up on a couple of questions. Both of you were talking about the islet cell transplantation work that has been done, and I just think it's worth noting, as well as the anti-rejection issues. The other issue that we have right now with using the islet cells from cadavers is that the supply is even if you could figure out the rejection issues, you would have such a low supply of existing islet cells that you couldn't possibly treat the existing populations. I'm wondering if either of you or both of you would like to comment on that.
Well, my comment would be that that is likely to be true. The options of stem cells, I think, is really a true one. And while we'll still have to get around the rejection issue, because that's been sort of the thorn in the side of getting a cure, I think that stem cells still hold significant promise.
And that's because with the stem cells you can actually make new cells versus the existing research where you have to just collect them.
And hopefully immune tolerant so that they don't get rejected.
Right. Let me ask you along those lines. The NIH recent work of trying to approve new cell lines, is that sufficient to be doing the research that's out there right now on the stem cell research? And what about this issue of having cell lines that might have the genetic predisposition towards diabetes? What's the status from your perspective as private organizations?
There are now many approved lines for NIH funding. We think that's terrific. There are alternative sources for new lines from induced pluripotent stem cells, which are excellent resources. And disease-specific lines are being produced, for example, at the Harvard Stem Cell Institute with the technique of induced pluripotent stem cells, and they're making the cells available for study by researchers. They include rare genetic disorders as well as things like type 1 diabetes. So I would say the rate-limiting event today is funding for research to take advantage of the available material more than we need to make even more material this week.
Yeah, because not only did we have President Obama's expansion of the embryonic stem cell research, but just in the last few years we had the discovery of the iPS cells. And so now we need the funding to capitalize on that. I just have one more question for both of you, which is a lot of your testimony and the previous panel's testimony was around this concept of an artificial pancreas. And of course, as the parent of a diabetic, I follow these research developments with interest. And I think the closed loop system will be the next big step. How far away are we, though, from really developing to being able to get clinical trials of the closed loop system and then to actually have it be widely available for folks?
Well, there have been some clinical trials that have already been conducted and have shown efficacy in small numbers of patients. I think the difficulty right now is having sufficient funds to be able to do it in larger populations of patients, and of course to research needed to make it more user friendly. Right now, the artificial pancreases that have been studied are still bulky and large, and they're very effective, but not particularly adaptable to everyday life, and that's what we have to strive to do. But I think we're certainly heading in the right direction, moving quickly, but perhaps not quickly enough.
Dr. Goldstein?
The technology is a bit cumbersome at the moment. Not every teenager likes to wear it, and if we can package that and shrink it and make it more user-friendly and get more widespread use, we'll be able to take advantage of current technology. We need improvements. We're funding work that's going ahead full blazes in terms of understanding how to set an algorithm to describe an exercise situation or sleeping at night situation or the infinite variety of details that a person might go through. But our notion is that to whatever extent we can automate the technology, we'll get those tough-to-treat patient populations like adolescents and teenagers to use the technology.
Right.
And that'll make it better for everybody.
Thank you.
I'm going to try to finish, guys. I know you'll have 5 minutes each, which is fine, because we have not only a series of votes, but also motion to recommit, so it'll probably be at least an hour. So we're going to try to finish. So we'll go to Ms. Capps next.
Thank you very much for your testimony and also for your patience getting through this very long day. 2 questions for each of you, and they can be brief, and we can move to Mr. Space. One couple for Dr. Goldstein. In your testimony, you state that type 1 diabetes typically strikes in childhood, adolescent, or young adulthood. Then you note that the incident has increased, particularly among children under 4. I wonder if you could briefly give us a couple of reasons for that, if they're known.
I wish I could give you a couple. No.
Or some kind of
I should say
information.
2 things quickly. About half the cases come in people 20 years old and older. So type 1 diabetes is not, strictly speaking, only a disease of children.
Right.
What's happened from the epidemiologic studies in the past 5 years from both Europe and the United States is, unfortunately, we're seeing it in younger and younger children in a more aggressive version.
Right.
And since nothing much has changed in the genetic structure of people, the assumption is that's related to something in the environment. So studies are focusing on identifying a theoretical virus that could do that.
Okay.
Some antigen within your body.
So there is no clear path, or and therefore we need a lot more research in this area.
We do.
Okay. Let me move on because you described also the disproportionate burden of type 2 and gestational diabetes on certain groups. I wonder if this also holds true for type 1. And can you tell us whether there are certain age groups beyond children under 4 that are particularly affected by type 1 diabetes? And, you know, with ethnic, racial, whatever kind of groups that you have
today,
understood.
Type 1 diabetes appears to be an equal opportunity disease, and the numbers are fairly similar across ethnic groups. Where it's extremely important, for example, is in, let's say, Los Angeles. If we'd like to get the technology into certain areas of Los Angeles to treat ethnic groups with type 1, that's a tour de force because that's not easily done without an army of educators and third-party pay, et cetera. So we have some of our artificial pancreas researchers working there on that. That's a hope for the future.
I see. So it's going to depend on some other things. Maybe that will segue into questions that I have for you, Dr. Henry. These could have been interchanged with either each of you. Earlier today, Dr. Albright was talking about in testimony that CDC is actively working with the First Lady and Let's Move, that campaign to provide expertise in healthy eating and physical activity as a way to deal with diabetes. They are also sponsoring the diabetes CDC as the Diabetes Prevention Program Master Trainer Curriculum. I'm particularly interested in types of prevention, research, and activities that will really work, and that ties into areas like that they would work with particular community groups. And Dr. Henry, maybe you can tell us more about some efforts that your organization is getting behind and the advocacy community is working on in terms of outreach, specifically how they're being tailored to meet the needs of individual communities.
Yeah, I think one of the major ways is in the application of the Diabetes Prevention Program information, which was highly effective. As you know, a 58% reduction in the development of diabetes in individuals who are able to lead a healthy lifestyle. So clearly one can make big inroads in that. Now the task has now been to take it to the community level. And that has been done, the translational part of that program has been initiated, and we're obviously very supportive of that, and has been done for a reasonable amount of money, as you heard, in the range of $250 to $300 per year per person, which is, I think, a reasonable amount of an expenditure. So I think that's right now where our major efforts are going. But there are also many preventative and efforts that are being directed truly at the pancreatic beta cell, which not only does it decline and cease in type 1 diabetes, but it declines progressively in type 2 and is a major contributor to many of the complications through poor glucose control. So there is, again, a great deal of research focusing on preserving the beta cell and preserving and also treating the insulin resistance that you heard about, because we now know that efforts directed at treating the insulin resistance, whether it be through lifestyle modification or through medications, prolongs the pancreas and gives it a longer period where it can produce sufficient insulin to maintain glucose control.
All right. Thank you very much.
Thank you. Mr. Space.
Thank you, Mr. Chairman. Thank you both for being here today, and certainly want to echo the remarks of my colleague, Mrs. DeGette, regarding how valuable the work that both of your agencies do is. I have, I guess, Mr. Henry, Dr. Henry, for you first. Your testimony references special populations as being especially prone to contracting diabetes. And there's been some talk today about ethnic minorities and Native Americans, and there hasn't been much said, however, about the geographic and demographic breakdowns. My district is in southeastern Ohio. It's Appalachian Ohio. It's a very poor, very rural district that some of my counties have actually twice the incidence of diabetes than the national average or even the statewide average. And I'd be interested in your thoughts as to whether those types of demographics, location or access to healthcare facilities or poverty, whether or not they have negatively influenced the diabetes incidence rate, and whether your studies are accounting for that and what can be done to offset that.
Yeah, I think that it seems unquestionable that is the case, and access to care is definitely one of the limiting factors, because in many cases there is prodrome, not only obesity but different forms of obesity that precede the development of at least type 2 diabetes and individuals at risk for gestational diabetes. And certainly those populations, they need to be effectively treated and have access to care. Just as well, I think that healthy lifestyles are difficult when you're poor. It's very difficult to eat the fruits and vegetables that we've talked about, and I think that also increases the likelihood that individuals with at genetic risk of diabetes, which it is clearly has a genetic component, are more likely to develop diabetes. So I think that those are real issues that that have to be addressed, and I think that better access to preventative technology as well as better treatment of the comorbidities will translate to a reduction in the development of diabetes.
Thank you. And Dr. Goldstein, thank you, by the way, for meeting with me earlier today and taking time out of your busy schedule. We have about 2 minutes, and I'd like if you could give us just a very brief account of how the NIH funding works in conjunction with foundational funding that comes from sources like ADA and JDRF, and how it works in conjunction with industry sources of funding for research and development from biotech and pharmaceutical companies.
So here's the 2-minute version. We work very closely with the NIH to do complementary things, so we're not funding the same things. And I would say the most important piece of information is that the NIH, which has made a historically important investment in basic science and discovers new things. To develop those things, you have to pass them off as you go along. So initially, new discoveries get in the hands of small companies. NIH has a modest program. JDRF has a modest program to encourage small companies to develop things. We like to nourish them along the pathway to get into proof of concept clinical trials, which is about the first place that large pharma becomes interested after you've already got some data. And once you've got the data in a phase 3 trial, large pharma becomes very interested. So, for example, the anti-CD3 I spoke about, 2 large pharmaceutical companies are both taking that to market. And it costs lots of money to do that. We can't afford to do it, nor can the ADA probably. Early on, NIH gets us the discovery. But once you hit the small company level and the small biotech and the small investigators, the handful of people who are moving the next generation of science along, it's really hard to get money to do that these days. Venture capital has dried up. And the foundation world has said, that's a gap we need to think about filling. How could we do it wisely? And that's exactly where we're focusing our more limited resources in a more strategic way. So we, frankly, pick and choose. We try to take something more promising and try to move it along to the point where it can either move or not. And that's a partnership that I would argue has served the United States of America very well in terms of being a model for how to do things for people. And at some point, the big clinical translation apparatus comes into play, and NIH has played an important role in doing that as well.
Thank you very much.
To end.
Thank you.
Otherwise, we're going to miss the votes. Listen, thank my colleagues and both of you for your presentations. It was very helpful. The way we work is we have about 10 days to submit written questions, and particularly since Mr. Chairman Rowland had to leave, I'm sure there'll be some, and the clerk will send you those, and then we ask you to get back to us as quickly as possible. But again, thank you, and I know there's a lot more to be done on this issue, but at least we had a beginning here today. And without objection, this meeting of the subcommittee is adjourned.
sir.
You did? The
LA?
Sensum?
Well, yeah.
Screw hooks are going to do is not only hold the cord, but it's also going to determine where